which is Beyond the Surface, Neurodivergent Practices for Children. The session will be chaired by so the session will be chaired by Professor Dr. Kaptan Singh Sengar. Sir has been a distinguished professor, and currently he is Sir is currently working as a distinguished professor in SGT University, and he has an experience of over 38 years. In the past, he has served as an additional professor in clinical psychology in RIMPAS. He has also served as professor and head in Adams University, Kolkata, West Bengal, and as resource person in various organizations like Disaster Management Institute, Jharkhand, and Judicial Academy. Sir has more than 120 research publications and is the editor-in-chief. He has served as the editor-in-chief in Indian Journal of Clinical Psychology from 2012 to 2019. Sir will be chairing the session. I please welcome Sir on stage. And Sir, I would like to request Ms. Lakshmi Pandey, Assistant Professor and Assistant Director of IBAS, to kindly felicitate Sir for the session. I would now like to request our invited speaker, Uday K. Sinha sir, to come for the lecture. Sir is additional professor and former head in Department of Clinical Psychology, IBAS. Sorry, sir has a work experience of 31 years and more, and his major contributions has been in numerous research studies in policy research and mental health sponsored by WHO and ICMR. Sir has published extensively in reputed mental health journals, and he has served as subject expert for various organizations and has acted as resource person for Judicial Academy, DSLCA, CBI Academy, DIPR, DRDO, and RCI. I would kindly request Sengar sir to please felicitate Uday sir for the session. So without further delay, I would request sir to please take over and start. Okay.
I think the head count is more than my expectation. Uh,
So, good morning to all. And topic of the this lecture is Beyond the Surface: Neurodivergent Practices for Children. So, neurodivergent practices. When we talk about the children, that neurodivergent is just an umbrella term. Cater different type of the neurodevelopmental disorders. And on that particular topic, Professor Sinha will deliver the lecture. Thank you.
Thank you, sir. Uh, I think the topic is well framed. It begins with beyond the surface. So something which we are going to discuss here is not at the surface. So it's a beyond. I think it should have been under the surface. That would have been more appropriate than beyond the surface. But anyway, uh, the essence here is that we are going to discuss something which is not usually kept in our mind when we engage in the practice of clinical psychology with children. And they are very important, and discounting them in our practice can lead to severe damage, which may not see or perceive at the time of the practice of clinical psychology, or whatever techniques we practice with neurodivergent individuals, or here in this context, children. Uh, See, as Sir said, neurodivergent is a bigger concept, a larger concept, which I'll try and explain that. But before that, I think the context in which we will be discussing the practice of neurodivergent principle with children need to be understand uh, in the form of developmental condition, neurodevelopmental conditions, which was hinted by Sir. And we know that the neuro developmental condition which we encounter in our practice with children is, uh, I mean, has a huge range, including autistic spectrum disorder and specific learning disability, ADHD, language communication disorder, and many syndromes, the endless syndrome, and few of them are mentioned here, but they also have lot of implications for cognitive intervention, and they are likely to reach to uh, mental health professionals or psychologists who are working in pediatric or child mental health setup. So this will have to keep in mind to understand what exactly we are going to experience in next few minutes. Now look at the prevalence of. I have quoted two recent most study which has been done in India. One is in Kashmir and the other one is South India somewhere. So the total prevalence of neurodevelopmental disorder is between 12 to 16%. And looking at the entire population of children in country, you can assume the number of children who are likely to suffer from neurodevelopmental disorder. Nearly 60%, or uh, approximately 60% of the population of the country uh, is population of the children, right? Allow me to exaggerate to some extent, but the huge number of children are likely to suffer. And so when we discuss an approach which requires certain specific attention, we are discussing for such a huge number of recipients who are going to get benefit. Uh, Now, the usual approach which we all follow, those who are working in specific conditions where they are looking after children's and their problems, they can understand that the usual uh, the format of consultation and service delivery is like this. So there is a first consultation, the parents or some agency is that there is a need to consult, and then they reach to the consultant authority somewhere. The consultant authority or organization does the initial workup and clinical assessment for the diagnosis. Then diagnosis is entertained. The child is taken for specific assessment. Then accordingly intervention is done and provided, and according to the need, the assessment or reassessments are done. So this is the usual format of service delivery. Now this format is fairly structured format. There are they are well formatted, and the fixed criteria. I mean, if you are diagnosing somebody with a specific learning disability, there are criteria. So that fixed criteria is, or so is the case of hyperactivity, attention deficit disorder. So the criteria is very fixed, and the intervention which are provided is generally module based. There are module available to provide intervention, right? And what is ultimately done is we try to take them towards the path of normalization, right? This is norm, and the child has to function within this norm, and that is what is done. Now here comes the important aspect of neurodiversity. Now, are we familiar with this term? I think we all are. We all know that there are concept of individual difference. Each individual is different and unique. Individuals tailored intervention, we do talk about that intervention has to be tailored as per the need of the individual. Now, what does this mean? This means that the formulated or structured module based intervention may not be applicable because you are talking about each individual. So if there are 100 individual to be given intervention, means there has to be 100 different formats, right? But the thing which is done is not done in that way, right? Neurodiversity. The term appears to be very medical in nature, but the neurodiversity term is not medical. It has emerged from the social movement in Australia, where people tried advocating the unique need of people who are having certain conditions. Basically, the self-help group were autistic, and the adults who were suffering from the attention deficit hyperactivity disorder. So their unique need in the society and what they uh, require in terms of their growth and development. I think that was the factor behind a social movement, that they argued that the brain is different. Each brain is different and unique. No brains are equal, right? So everybody has to have been given whatever is the possible according to their unique requirement, unique need, right? And unique position in the, for example, if education has to be given as per the unique need of the child in the school, right? So this is the idea behind having the term neurodiversity. Now, why they picked up the term neurodiversity is because for neuro, they mean that it will involve or accommodate entire cognitive operations which are required in the course of development. And diversity is because this ability is distributed in a very divergent manner. So they found that the concept is very appropriate and can explain uh, the actual position for which the particular term has been coined. Now, see, neurodiversity is not the medical condition, right? And it does not mean the disability. Now, what we do when we get the children who are having neurodevelopmental condition, whether it is autistic spectrum disorder or hyperactivity attention deficit disorder or learning disability or the disorder related to sensory perception. I think we try and look at the child from the perspective of the criteria which are having. The child is having all these symptoms, right? And that makes the child uh, suffering from this particular conditions, right? And we use the same criteria for every child. Now, how much we try and focus on the uniqueness of the child in our approach or assessment in our clinical setting. Those who are working in clinical setting, I think I can find a lot of trainees and working professionals here, so they can relate with it. How much the individual factors are given the room there, right? We ask or we the informant, the parents, they come and tell that look, my child is having this problem, this problem, this problem. Accordingly, we inquire from the parents, क्या क्या difficulty होती है, क्या क्या. Have we ever asked the question like, tell me what your child does? I think this must be happening, but not very frequently. We never ask what the child does, right? We ask, or what is reported from the parent side is what the child is not able to do, the deficit part, the abnormality part, the part which explains the position of being disabled in certain conditions. So I think there neurodiversity has given an entirely different approach where we are supposed to focus on the unique strength and positive aspect of the children, find out the factor which are coming in the way of those positive or strength to get due expression in their activities and speech and everyday challenges, and provide proper accommodation so that those factors which are preventing them to excel in their unique strength, right, and that those are minimized and the child is getting adequate opportunities and setting where his strength can be excelled with the help of the professional input. I think that is the whole idea behind advocating the neurodivergent um, practice with children, right? Now we all are aware of that. These are the common conditions which we encounter, right? And we all also know the exact prevalence and incidence on all those things, because I feel we all are professionals sitting here on some of the other capacity. So I do not have to go into the details of how prevalent they are, but these are fairly common conditions which any organization running a pediatric setup or neurodevelopmental clinic, they are likely to encounter the whole range of neurodivergent condition. Now, neurodivergent practices for children include creating predictive environment with visual support, respecting and adapting to the individual sensory needs, and focusing on strength and effort. Though the placement of focusing on strength and efforts is heard in sequence, but I think that is the most important component of neurodivergent practice, where we are supposed to identify the unique strength, which usually we do not do in our clinical practice. Right? We just look at the symptoms and that becomes the baseline assessment and BO, and that serves the pre-intervention assessment. And then whatever is intervention we do, if the child is hyperactive, we try to reduce the activity level. If the child is not able to focus on attention, we try to teach the child different method of enhancing attention, irrespective of several other things which are not either observed or reported by. And there it comes something which is not at the surface. We'll have to identify them. Uh, these are the components which are important in neurodivergent practices with children. Schedule, offering sensory play, building emotional vocabulary, teaching adaptive coping skills. right? These all are very similar to whatever is done with it. But the content and method of doing it differs, right? When it is uh, to be called as neurodivergent practices. Uh, we'll avoid this. Now, focus of neurodivergent practice is not on dysfunction or deficit, as we usually do in our clinical practice, right? Person's unique strength to fill in the gaps and help them to adapt to their environment, whether that environment is either school or social setting or at work, family or clinical setting. So identifying the unique strength is the most important aspect, and how to do that is very important. So definitely, since this is something which is not commonly appreciated and utilized, it will not become obvious easily. So the clinician has to change the position in terms of spending numbers of hours with the child, and also changing or modifying the style of inquiry with the family members, right? And also requesting the family members to keep the record of the entire repertoire of child's activity from morning till night. And from there, one has to pick up the strength part. See, a child might be having ADHD, but if any activity which is done within 2 minutes time period, child is very, very good in doing it, right? So, uh, showing the talent within the specified time frame is the strength of the child. So whenever I try and introduce any intervention, that particular strength is required. A child who might be having the sensory processing related issue, right? Being affected by certain order, certain smell, certain temperature, which usually we do not care for knowing from the family in regular practice, right? If we do the detailed analysis of a child who is hyperactive and take the record of entire 24 hours, then we'll find that certain hours the child is more active as compared to some other hours. So there is a lot of variability in showing the difficulty. Now, if you try to find out what happens there, so for example, in one case, it was discovered that between 11 and 12 o'clock, the child shows lot of behavioral issues in the family. Now, what happens? Now, the analysis showed that that was the time when mother used to cook, and certain smell of spices which are to be used in cooking food, that used to stimulate the child too much. Now, do we appreciate such hidden aspects in our everyday practice? No. But these are something which requires to be understood. Now, what was suggested to that family that whenever you cook, you put the child somewhere where the smell of the particular spice does not reach, and look at the change in his behavior. And it made significant change. This is the approach which is described by neurodivergent practice, where you go into detail, find out the exact difficulty in adaptation of the child along with the strength, and look at what else you can do to modify it, enhance the adaptation. And there are a lot of sensory issues, and we all know that the sensory issues are more common in children who are suffering from neurodevelopmental disorder of any kind as compared to children who are not suffering. So this is something which is very important to recognize and identify. So these are two key issues in neurodivergent practice. Find out the strength the child is having, and it depends on how skilled you are as professional, how expert you are in eliciting uh, strength, and what is your attitude. See, the attitude is very important here, and the attitude should also involve, other than clinical, the social dimension, because the entire genesis of um, neurodiversity has come from the social movement. So how much you are socially attuned as a professional, all of us may not be. So we need to uh, have a particular attitude also along with the clinical or medical expertise. So uh, now these are some of the strengths which we may not have the practice of looking at them in our usual day-to-day clinical practice, irrespective of the setting and the institution or organization you work in, right? So in different domains, now in perceptual domain, the discriminant ability to discriminate even a slight uh, uh, variation in the phenomena, the acuity part, how good you are or how accurate you are in perceiving this. We all are must be aware of something called, which we call idiot 7. The some of the skills in children with autism are very different, extraordinary, beyond the imagination and belief system. But why they are called idiot? Because those skills do not have any practical application in day-to-day life, right? Now, since we are not able to recognize the practical application of those extraordinary talent, we say that it is good for nothing. It is our inability as a professional, or as a provider, so to say. So this is our responsibility to check whether this kind of ability which the child is having can be utilized in what manner. Let me share one very true uh, experiment which was done nearly 4 decades or even 5 decades back in Germany defense services. Now, defense services, just imagine the situation 5 6 decades back, where we did not have the digital technology, right? So everything used to be handled manually. Now, defense services deals with a lot of secret and those documents and information which need not be shared with anybody. Now, who would be the appropriate personnel to uh, deploy in such section where we'll have to ensure the security and ensure that the information is not concealed, not shared, right, or leaked. Now, what they did, they identified few person who had autistic spectrum disorder, but at the same time they had reasonable cognitive abilities, and trained them to handle the secret file in the department, thinking that their social interaction is minimal, almost absent. See, the chance of leaking information is zero, right? And which was proven that the frequency of information being leaked got reduced significantly. Now, is it not neurodivergent practice, right? Now, any talent which people are having, should not go waste. That can be seen as strength, and we have to identify the hidden strength and see that how those strengths can be utilized. Now, the policy of government is inclusive in nature. See, all policies are for everybody. So similarly, education is also inclusive. Now, many children who are having the characteristics, their capacity to remain at one place is less. They have difficulty in sustaining their attention for longer time period, and they have difficulty in controlling their impulses, particularly in the time of being overstimulated or being not able to control the sensory experiences to reasonable extent. Now they start uh, they are in the same situation where the children who are not having all these, and the method of teaching in the classroom is same, right? And then what we say that this child is not picking up, right? Other children are picking up, this child is not. That blame is on to the child. Now you make me to sit near the window, and it feels very cool sensation in my ear, and it makes me so uncomfortable that I am not able to concentrate. And if I am not able to concentrate, I will definitely not learn the way others are learning. So are you considering my specific extra need and then utilizing that in the course of education? And if you are not doing that, you are blaming me for not learning, and that is what is happening, right? I am not at all, don't mistake me, I'm not at all saying the current treatment method across this neurodevelopmental condition is faulty. I'm not saying that. I'm saying that there is a requirement of changing the approach, right? You go ahead with stimulants in the or CNS suppressor in the treatment of ADHD, but at the same time, you do not forget to utilize the neurodivergent approach. These are different areas where you can elicit the strength in children, right? Now, many children they give undue attention to the details, right? To the extent that we as professional or adult around the child who are involved in either teaching or training the child gets fed up. फालतू का क्वेश्चन पूछते हो, don't ask all these, right? We do not have guts to take that as their unique strength and modify that, utilize that in teaching the child. I think that is something which is needed currently. I will not go into the exact details as to what to do. I'm here to raise the issue and the relevance of neurodivergent practices with children and how important it is. I'm repeating it intentionally, the same thing. And the reason to repeat it is I'm ensuring that it gets registered in our mind somewhere, right? And that is the objective of repeated stimulation. So strength-based approach, clear and multi-sensory instructions are given so that we are ensuring that instruction which are being provided to the child is reaching the child, right? Not only the verbal instruction, not only the instructions written in on the board, हमारे एक्स जनरेशन के लिए ब्लैक बोर्ड, नए जनरेशन के लिए अल्फा बीटा गामा जनरेशन के लिए स्मार्ट बोर्ड. So it's not only in the form of auditory instruction or visual instructions. If some other method is required because the child has limited channel to receive instructions, and that I have identified in the analysis or assessment, and hence I'll have to ensure that multi-sensory instructions in a clear manner is given to the child. Personalized accommodation. As I am saying, many children, they are very sensitive to smell. They are very sensitive to temperature. They are very sensitive to. I have a nearly 9-year-old child suffering from autistic spectrum disorder. Now, fortunately, when he sits next to me, his oddities in his behavior is less as compared to he sits. And this is something which I have observed. He calls me Dadu. He calls me Dadu and comes and hugs me, right? And then he tries to pull his chair next to my chair because he is also ensuring his own comfort. And many a times parents, out of courtesy and mannerism, they have pulled the child towards them, which he has disliked. Right? Then I said, I mean, forget this. Let him sit wherever he feels comfortable. Right? We all to our children try to give them instructions as per what we feel effective or appropriate. पढ़ाई बैठकर ही करनी है, पढ़ाई करते समय और कुछ नहीं होना चाहिए, बिल्कुल शांत होना चाहिए. हाउ डू यू नो दैट अ चाइल्ड विथ parallel musical stimulation concentrate more as compared to keeping quiet because that is bothersome for him? So the point here is that the unique characteristics, the unique strength, the unique ability has to be appreciated, identified, and utilized in the practice. The assessment has to be different here, different assessment. It's not applying Isha in a autistic child. Forget that. Some of our practices are so erroneous, it doesn't lead anywhere. I'm sharing it with my personal experience. Assessment of ADHD. There is an instrument called ADHD T, right? Which tells you that there is an average possibility of ADHD. Now tell me, what is average possibility of ADHD? Right? I mean, such kind of practice seems very, very insensible, right? And need to be stopped, right? Which is not helping anybody, either professional or the client or the child. Assessment has to be very different kind of assessment, and definitely beyond the use of the rating scales. I know Connors abbreviated rating scale or CARS or ISHA. I think lot of emphasis is to be given on what the child does every day, right? From every activities of the child, right? It doesn't matter if it takes 1 week only in completing the assessment and identifying few relevant uh, stuff after the assessment. Positive and inclusive learning opportunities. I mean, we do not have to. Inclusivity is by rule, right? So every educational institutions have to practice inclusive approach. Positive will have to add. I know positive in the context of the experience of the child, not what we understand as positive, right? Right. See, important here is assessment has to be multifaceted approach, follow multifaceted approach, which also includes the rating scales or whatever we are using here. But at the same time, lot of information from caregivers, educators, the peer group, if that is possible in certain age group. So whatever sources we are having, I think we need to and if there are specific cognitive tests available to identify the strengths and challenges. I don't think there are many, but if at all exist, we are aware of, we cannot hesitate to use them. These are reminders, the bell of, okay. Reminder. Okay, sorry. Hmm. This is very important, sensory, because we do not, routinely, easily appreciate this or do anything specific to know this unless the condition is very severe. But sensory processing challenges is something which is very important and can be a huge hurdle in picking up the desirable behavior or communication strategy. And either the child can be over responsive to sensory stimulus, or merely a small um, blink of light can create a huge behavioral discomfort, distress in the child. Or okay, so these are either the child respond in less intensity or magnified intensity. We'll have to appreciate them, and it is there with all kind of senses, including proprioception and interoception. These are few of the indicators which can give you indication that the child is finding difficult to process sensory stimulation. Excessive movement, running, jumping, right? Hand clapping, lot of stereotypy behavior in the autistic child might be because of the inability to process the sensory stimulation. So these all are the expression of the distress or impact of stimulation. Now, play is very important technique and method to identify these strengths, right? And there are suggested strategy, play strategy with the children having neurodevelopmental conditions, right? Uh, Difficult to establish a sensible, meaningful communication. So simply follow their leads. What they are doing, you just follow as the clinician or service provider. Sometimes imitate their pep. Doesn't matter how silly, stupid it appears. You imitate the same thing, and that creates the comfort for the child. Narrate and label what the child is doing. Giving commentary on that. Say that very good, well done. He did it nicely. So narrating, labeling, engaging at their level. So many a times, leaving your comfortable revolving chair in your consultation room, sitting on the floor along with the child, and then trying to follow all these. I think many a times that helps a lot. Use toys to enhance stories and songs. So so these are suggested strategy, play strategy, which can help us. Now, unpredictable behavior in children who suffer from neurodevelopmental conditions. Many times you cannot predict, but you find that there is a escalation in their distress. Right now, there are certain techniques or certain strategy which have been suggested, which can de-escalate their arousal level. Right, remaining calm is the most effective strategy. Right, so that also challenges your potential as therapist, right? So remain calm, do not get upset, right? Change the setting if possible, right? So changing setting means changing the material, changing the sitting position, changing the corner where you are interacting with the child. So any kind of change in setting can help. And respect. Don't never try to you know physically compose the child or the client, right? Even by patting or trying and holding and hugging. Many a times we feel the child is small, उसको hug कर लेंगे तो वो शायद शांत हो जाएगा. I think this is a mistaken view. You know? So the neurodivergent practice has not prescribed to that approach and say that never enter into the person. So these are few things which can help to de-escalate their emotional arousal. Family also requires to follow certain things which, right, can be suggested to them. I'm not going into details. Now, at the end, let's all advocate for neurodivergent uh, approach or neurodivergent practice. Right? Use as much as possible neuro practice. Even if you are at the training phase of your, try and use some component of neurodivergent practice, and definitely advocate. I'm not saying only neurodivergent, but practice which is neurodivergent in nature is needed. Thank you very much.
So, thank you, Dr. Sinha. Please take a seat. I think this excellent presentation of Professor Sinha might have taken you somewhere else, and you might have able to learn something differently. Because when we talk about the neurodiversity, it's a very simply the sociologist, Australian sociologist in 1998. It is not very old concept. He coined this term with the hypothesis that no two brains of human being are similar exactly. The term exactly keep in mind. So there is difference. What we are doing in clinical practices, go and do the CBT, go and do the emotional focus therapy, go and do this. I'm talking in general, not same practices we are applying in the children's also. Do the behavior modification, do this and that. It's not. Every child needs a different type of approach for their different type of the problems. No two child can be managed on the same type of the therapeutic measures. I used to say my students, you have just for the example I'm giving, because most of all of I think the student and majority of them, they need to learn. When you are giving the IQ, doing IQ assessment and giving, IQ is 115. How does it matter to that client or family members or community? Whether it's 115 or it's a 15. How does it matter? No. Here you need to mention the qualitative features, which area that child is having the deficit and which areas are performing better in comparison to other areas. And accordingly, you can guide the parents and you can tailor your program for the management. So same thing are here when you are taking the SD, LD, whoever so. It's not that you can use the same type of the therapeutic measures. So it's a neurodiversity give you the light to go on the different type of the thinking to diagnose the case and to management. Three areas are mainly there. Number one, identification of the problem. Number two, the management and what child can do. That's a more important part of neurodivergent practice. What the strength child is having. Accordingly, you will have to tailor your program. You there they have neurodivergent people have said that you are not going to change the child. Rather, you are going to enhance their strength in that particular area where they are. So this much whole concept of this neurodivergent practices are there. I again thank to Professor Sinha for giving such a nice lecture, and hope that you people might have also taken something an idea, because you majority of you are newcomer. You need to know these are the things. Thanks. So anybody has any question? हमने तो summarize ही कर दिया ऐसे. Anyway, but still I am giving the opportunity. If somebody has any doubt, any query, please come forward.
Anything to add? Only down the-
अगर किसी को किसी तरह की कोई शंका हो, तो उस विषय में हम आप सभी लोगों को स्वागत करते हैं. कोई अगर प्रश्न पूछने की अपेक्षा हो, तो भी हम आपका स्वागत करते हैं. And keeping mum not asking the question goes that either everybody has understood everything or nobody has understood anything. Yes.
Is in terms of teaching, at what point are you teaching adaptive coping skills, and at what point does that also influence? Thank you. I think I was audible. Yes? Yeah. At what point is it still teaching adaptive coping skills, and at what point is it converting into teaching them how to mask their difficulties? And I think I'd just like to hear your thoughts on that.
I think, thanks, Nuku. Important question. I think there is no particular, no suggested format for this. I think it is the evaluation by the service provider as well as the other important stakeholders, including parents. And how the child has acquired this skill. How next is to be decided. Definitely, the next what is to be decided, that has to be dependent on the child's strength, the same principle applied there. Right? So I don't think much scope to be in dilemma, right? If one has learned A naturally, the next will be the B stage. So follow that. And then that, what can be the B after A, that can be decided based on either use of certain scales or rating scales which are already existing, or you can create your own that with the help of parents, or ask the parents, because many a times any family B, the child may not require a mechanical skills too much because the family cannot afford that. So if this is something which is important for the child, that can be taught, or the child can be trained accordingly. I think these are important. The principle remains same, child center. Right? And you can add another important element. The child center also involves the immediate social milieu where the child is living. So the family's perception is also important. I think these are the principles which you all can follow and decide.
Do we have any more questions?
In this case, there I could not, but I am supplementing. Actually, two things are there. Number one, the question is to you are that you will learn through the practice. When you will see the number of cases, you will learn the requirement of it. Accordingly, you will have to pay. Number one. Number two, in cases of children, what you are talking about to talk to child are having very minimal load. If only family caregivers
those who are there whole time, taking the care of that child, they are more important and key person who can be given the proper education about the problem, hope, sustainability of the improvement, how it can be managed, what the things they will do. That is what.
Thank you, sir. Thank you for the lecture, and thank you, sir, for adding such valuable insights. Uh, after this, we'll break for lunch. As you know that we are running quite late, so we post lunch we will come back here for the symposium, which is the risk assessment of self injury, which is also a CRE session. So it was before lunch, but since we are running late, deep apologies for that. So we'll be doing that post lunch. In the meanwhile, I've shared, was a CRE session, so I've shared the link for the evaluation sheet. Please make sure that you fill that form in order to receive the CRE points, right? Thank you.
नहीं अभी इमीडिएटली नहीं इसके बाद काफी बाद मतलब लास्ट सेशन हाँ इसी हॉल में यस
Good afternoon, everyone. Um, welcome back after the lunch. So, we will be starting with the first symposium, which is risk assessment and management of self harm. Before we start, I would like to introduce and request our chairperson, Professor Dantilal Dubey, sir. Sir, if you could kindly come on stage and for chairing the session. Professor Bankalal Dubey, sir, he is the Global Director of Dubey Healing Center and adjunct faculty at University of Alaska and Professor Emeritus Amity University. Over 50 years of experience in clinical psychology, teaching and organizational training, and international authority on projective testing and personality assessment. With his major contributions, he is the author of Implant Personality Test, Understanding Unconscious Mind, which was published in 2019. There's more than 175 research publications and have won 5 Best Paper Awards in the US. He's the former president of Indian Association of Clinical Psychologists in 1985, and Somatic Inbred Society between 2012 to 2019, and again from 2024 to present. He is editor emeritus of SIS Journal of Projective Psychology and Mental Health, and he has conducted global workshops in Rorschach and somatic inward tests. Uh, and now I would kindly request Professor Dr. Anand Kumar sir to please felicitate sir. Dr. Anand Kumar, who is the president of Indian Association of Health Psychology. Thank you, sir. Thank you. So now I would like to introduce the speakers of the symposium today. The first speaker of the symposium is Ms. Rashmi Pandey. She is the assistant professor and assistant director of IBHAS, Amity University, Uttar Pradesh. She is a registered clinical psychologist with 18 years of clinical and academic experience of supervising psychologists. She has numerous publications in national and international journals and empaneled visiting expert for assessment of institutes for MPhil Clinical Psychology Program from Rehabilitation Council of India. Also member of editorial board in Journal of Psychology, Psychosocial Wellbeing. Invited resource person for various CREs and lifetime member of CPSI India. Her areas of interest are addiction psychology, CBT, psychological flexibility and well-being, and neuropsychology. And I would like to introduce the second speaker for the symposium, Dr. Sonia Poor. She is a professor of clinical psychology at IBHAS, Amity University, Uttar Pradesh. She also has more than 16 years of clinical and academic experience with numerous publications in national and international journals, and she has been invited by various universities as subject matter expert in University of Delhi, JNU, Jamia Millia University, Jamia Millia Islamia University, Manav Rachna University, and her areas of interest lies in trauma-informed approaches, addiction psychology, and CBT and psychological flexibility and well-being. So now we'll begin with the symposium, and I would like to request both Dr. Sonia Kaur and Ms. Rashmi Pandey to please join us for the symposium.
A very good afternoon to all of you. So today we'll be presenting the topic risk assessment of self-harm, that is NSSI. So basically, when we have to define NSSI, we will define it as direct, deliberate destruction of one's own body tissue in the absence of a intent to die. So generally, the common methods that are used for self-injury and suicidal self-injury is skin cutting, scraping, carving. 21 to 45% usually engages in banging, bruising, self-cutting, and 15 to 35% engages in burning their skins as a part of NSSI. NSSI is a very complex thing to understand. It is the intention The point that we need to understand about here is that there is an intention. The intention is to hurt myself. Though the intent is not to end my life, but to hurt definitely. So it is not a byproduct of any behavior, it is an intention. The intention is there. It is estimated that NSSI as a whole is associated with a 30-fold increase in the risk of suicide attempt when compared with the general population. Now, let us try to understand what are the psychological and social risk factors for NSSI. Talking about gender, it has been seen in various researches that the higher prevalence is among females due to greater emotional sensitivity and regulation difficulties. Adverse childhood experiences in terms of sexual abuse, physical abuse, family conflict, low parental support also contributes to the phenomena of SSI. Bullying and peer victimization, both traditional as well as we are in the digital world, so cyberbullying is very much present, is also strongly linked to NSSI and such. Mental health conditions comprises of depression, anxiety, emotional dysregulation, so low self-esteem, borderline personality, all these mental health conditions are associated with NSSI. And problem behaviors, once substance use, internet or gaming addiction, the temperament of being impulsive is also linked to higher risk of NSSI. The biological, behavioral, and cognitive risk factors, of course, along with the psychological and social risk factors. The physical components are sleep disturbances, chronic pain, fatigue, body dissatisfaction has been found to be a major contributor risk factor. Limited understanding of health and emotion regulation strategies. Central mechanism under NSSI is that inability to manage intense emotions effectively. And so across all the different studies, emotion dysregulation has been considered to be the major contributing factor to NSSI. Negative self-talk, sense of hopelessness, perfectionism, self-criticism also tends to reinforce our urges of NSSI. And within the environmental influences, the factors that has been found are stressful life events, peer pressure, lack of social support. So any factor that is contributing to an individual's distress.
पहले ये वाला चलेगा, ठीक है, उसके बाद ये वाला चलेगा, पहले ये वाला चलेगा।
What?
Is it comfortable? Make yourself comfortable. You want to sit somewhere or you have to arrange a chair?
Cleaner.
So any event in the life that contributes to the emotional difficulties and regulations of an individual, the probability of the individual resorting to NSSI increases. It's not mandatory that every time it will happen, but the probability increases. Now there are two models, the two prevalent models that tends to explain the mechanism of NSSI. So first is experiential avoidance model. This views NSSI and self-harm as an emotional avoidance behavior that I have been highlighting, and it occurs in response to strong emotions triggered either by the internal or the external stimuli. Now, the stimuli can be painful memories, negative automatic thoughts. The external stimuli can be having an argument or any kind of interpersonal conflict or intrapersonal conflict, or being continuously in a state of anger, sadness, shame, etc. And the vulnerability factors, according to this model, is tendency to experience emotions strongly, the negative emotions strongly, and at the same time having a limited capacity to regulate and moderate them. So basically, lack of emotion regulation skills and poor ability to tolerate any kind of distress is the uh, primary factors according to this model that contributes to unnecessary. So how does this work? MSSI provides immediate relief from emotional distress, and over time, then again it becomes the preferred coping method. Alternative coping strategies weaken or are forgotten. So every time there is a distress, emotional, high intense emotion individual is experiencing, we resort to MSSI to release that pent up emotions, and so the person feels good, and then again the same cycle, the vicious cycle continues. That's what is the model's explanation. So definitely the model proposes to build emotional regulation and distress tolerance skills for such individuals and address the reinforcement cycle to reduce habitual self-harm. Similarly, functional model of NSSI was given by Mack and Kingston in 2004. Now they explain that there are four categories of reinforcement mechanism. There is automatic negative reinforcement, such as if there is a self-injury that, as I already highlighted, it tends to reduce the negative internal state, then it is working as in the pattern of negative reinforcement. In the pattern of automatic positive reinforcement, self-injury creates desired internal sensation. So when I'm engaging into an act of self-injury, it is creating a kind of a sensation. So some individuals to overcome that feeling of numbness or emptiness, they tend to engage in this activity. So here comes the positive reinforcement component. Similarly, there is a social negative reinforcement. Engaging in such activities to escape certain unwanted social scenarios or situations, and positive reinforcements where the individual tends to get desired attention, support, or care because he or she is engaging into such activities. So these are the mechanisms of NSSI. Definitely, based on this model, the clinical implications talks about help make the individual understand the motivation for NSSI. So the function that is serving that needs to be understood when we are taking up a course of NSSI, and the functional assessment and alternative adaptive coping strategies has to be replaced. Now, how should we go ahead with the assessment of NSSI? Definitely, we have access to numerous scales and questionnaires, self-report measures that can be used as a source of assessment for SSI assessment. But a face-to-face interview definitely provides us with much more subtle and nuanced information, and also gives us that elaborate time with the client to understand that their non-verbal cues, their emotional state in that span of time, and that helps in the rapid commission part also, and definitely gathering lots of information. So a thorough clinical assessment helps understand the nature, trigger, and function of NSSI. requires asking a broad range of questions to understand the behavioral component, the emotional component, and the contextual aspect. So we can start from history analysis. When did the NSSI begin? What were the antecedents? What was the context? What are the typical triggers or life events and in the entire period of NSSI that the individual is engaged in, has there been a part when he or she has been abstinent from that, engaging into that activity? Is there an urge that keeps the individual pushing back from the activity of NSSI, and how they themselves manage this? Do they try to handle it, or they just resort to the NSSI part? Types of NSSI behaviors engagement. The different types have distinct antecedents, that means in different contexts, are there different patterns of antecedents that are propelling them to engage into such behavior? And what is their individual mechanism or tools or method to engage into NSSI? Time of the day, location, body areas targeted, hidden versus visible locations, meaning behind these choices. Which part of the body the individual is doing the exercise, engaging into exercise, and does that hold any particular meaning to that individual? So that information is needs to be gathered. Occurs in private or around others. So it is a secretive behavior or the individual engages in great intimacy public. So that also needs to be identified as a part of the interview. Any pattern of seeking or avoiding observation. Like they intentionally engage into such behaviors in public so that they can gather some attention, or they are secretive enough not allowing others to know. So that will have a different clinical and therapeutic implications. Associated factors, alcohol or substance use, whether there is a history or not, whether such NSSI states occur in any kind of a dissociative state, that information also needs to be gathered. And while the individual is engaging into such behavior, they consider this to be a self-inflicted punishment. Those cognitions needs to be identified. Along with this, the emotions of shame, guilt, self-criticism, negative self-talk needs to be identified. Different individuals may have different emotions. And post unnecessary episode, do they tend to displace or do they tend to remain themselves only? Also, the component of interview should include both immediate and long-term consequences meant for that particular individual and how it impacts his or her social relationship functioning, overall mental health, and other aspects. Definitely, we discussed this earlier that as a by interviewing the individual, we also need to identify and check upon the comorbid psychological conditions. Maybe the individual is undergoing depression, anxiety, personality conditions, and as a part of that, there is an emotion dysregulation. Part of that, they might be engaging in such activities. So that also has to be identified. So, by doing a functional behavioral analysis for one single episode of NSSI, maybe these questions can be helpful. A 24-hour period, do before several hours after the episode, identifying the distal and the proximal antecedents and consequences. What is the physical status of the individual, whether the individual is in low energy, is he constant, is he skipping meals, using medication, is he constant, interpersonal difficulties, arguments, emotional loneliness, sadness. So all these can be the probable antecedent factors for a particular NSSI event. So each event can have their own functional analysis. So these questions may be helpful. Again, frequency, duration, intensity of self-injury, short-term and long-term interpersonal and intrapersonal outcomes. So that whether they are getting attention, whether they are making other people listen to their demands whatsoever they have, or it is a release of their contact emotions, that's the reason they are using it. So that consequences and function it is serving for that individual needs to be identified. So now what are the There are few challenges when we try to assess individuals for NSSI. Usually, it's not that easy. They will not come on their own to declare that I'm engaging into such. So, as a part of OPD practice, we tend to screen all the probable individuals and have brief questions to like understand whether our detailed interview should be taken. But the difficulty that we may encounter is that they might be hesitant to disclose episodes of NSSI. So that initial access to their thought process and having that rapport so that can become comfortable, that may not be very easy in the initial phase. So client hesitancy to disclose episodes of NSSI for fear of being misunderstood or judged negatively. This means so usually at times it happens that they may present with some other difficulties and gradually they may become comfortable and share that I engage in such activities. They may not primarily come with this concern that I am engaging in skill scraping. They may come as a part of borderline personality condition. They may come as depression. They may come as with symptoms of anxiety, and gradually over a period of time, they may continue that they're engaging into such behaviors as well. This makes validation and not judgmental stance throughout all phases of assessment and intervention particularly important because secrecy part has to be addressed. And at times, the client may not be able to describe the reasons why they self-injure. So, for us, it may be able to understand that the emotion dysregulation component is very relevant to engaging into NSSI. But for them to explain themselves that what happens, maybe we will have to help and navigate them through this part also. So the client may not be able to describe the reasons why they self-injure, particularly where a young person experiencing difficulties understanding and communicating their emotional experience, for example, alexithymia. So people who are depressed, they might not be able to tell why they are doing it. Is it so to gain attention? Is it so to come out of that numbness? They are just doing it, but they will not be able to label it maybe. So that in that process, we will have to be more cautious about it. This may require further assessment and functional behavioral assessment. Over here, that this functional behavioral assessment will be helpful. To conclude, NSSI is a complex and multifactorial behavior that arises from the interaction of biological, psychological, and social components, which requires sensitive and non-judgmental approach. The purpose of assessment should move beyond predicting risk to understanding the functions, triggers, and emotional context. These three areas needs to be clear, and then maybe we will be able to help you better. A comprehensive psychosocial assessment should be incorporated for every individual presenting with self-harm to identify underlying needs and contributing factors. Thank you.
ये वाला शेयर कर दूं
एक मिनट पहले बाकी की प्रेजेंटेशन जो है ना इसको तो हम कल ही कर दें
ये वाला हाँ सबसे
देखो इसके जो ये देखो इसके गाना है बस अपने आप ही चला जाता है जैसे नहीं गया तो वहीं से यस थोड़ा सा
Good afternoon, everyone. So, what we heard so far was assessment of NSSI, self-harm is what we use the word because let's kind of understand it. I'm going to take it a little differently from the perspective that let's understand not what self-harm, you know, is saying a person who is doing self-harm is saying rather than what is being seen by others. So we will be on that idea. Right. So I think introduction is clear that has been covered also, and the intent is is differ from suicide act because there is not an intent to die. That is there, and it's most common in adolescents and young adults. I think gender equation also has been said that females tend to do it more than males. But what is self harm actually saying? So these are some of the narratives that we need to kind of look at because just seeing it from a very dry perspective, even when we are saying clinical, it shouldn't be dry. That's what our understanding is. But we need to kind of understand where the client is and connect with the client at the level that the client is. So, what is the client trying to say? There are a different ideas that can be there. Though the act seems same, they're hurting themselves. But the purpose behind hurting, though it's said that an intention is not to kill themselves, not to do suicide, so then what is the purpose? The purpose can be different. And that's where one needs to understand. And there is a study which I'm going to quote, which really took it, like I'm going to come to that, but here comes the part where there is a bit of question that needs to be done into these words when we are using them. That it's intentional, it's deliberate, it's non-suicidal. But is it really, the one of the dialogues that is there is that is it deliberate in the sense that does the person then because when we are saying intentional and deliberate, that then we are saying that the person has the control. So in that way, does the person actually has control when we already have talked about emotional dysregulation being there? So in emotional dysregulation, is the control there or not? That's the part that as a therapist, we should definitely question and help to develop rather control so that can be stopped also. Because if it is in my control, then I can stop it also. No? If I can do it, I can stop it also. But is that a question that kind of is something that I wanted to highlight in the beginning to bring this idea further when we are looking at management of self harm? That if we are going to look at it from that perspective, then we kind of lose a lot of patients and we lose our clients because we don't connect with them or we are unable to connect with them. And specifically when a lot of adolescents come with that emotional dysregulation, come with that kind of a you know emotional space which demands us to connect with them emotionally also. It can be very, very tiring for a psychologist who's working with them. And that's where to understand that how do we navigate that, that's my idea here. So this study actually was that there are three narratives. They took a lot of people and they tried to see what is the narrative that people with self harm are trying to like there are so many narratives that are there, but what is the common themes that are there? So the common themes come under three categories. One is I need to be punished. There needs to be some kind of punishment that needs to be done. So I deserve it. Therefore, let me hurt myself. The second is I is an unknown self because you know sorry there is a bit of a misprint there. The unknown self is actually I don't know what I'm feeling. I just don't want to feel this, and I will not want to feel it. Therefore, let me do something that will take away this feeling of negative experience from me. And the harm self is in a way that I am hurt and nobody cares. So therefore, these are the people that tend to do it in public and say that, see, I am hurt, yet you don't care part of it that is there.
So the case formulation approach needs to be brought around because we need to understand that, those are act seems the same, but there are different factors. There are different distal factors, which includes your biological factors, but there are also interpersonal factors that are there. And then a stress response and specific NSSI vulnerability theory, or the aspect which is there that, is it a self punishment that the client is trying to do? Is it social learning that is there? Because a lot of times you might find that, especially in adolescence, there is a bit of modeling that does take place when other friends are doing it, or they get connected with, that kind of an experience. Or is it, I just don't want to feel, this feeling is something that is unbearable to me and I do not want to feel. So that comes around there. So if we look at the model, then there are these approaches to management that come to my mind. But, one, because there is also abuse and neglect generally in the childhood, and there are adverse childhood experiences, so there needs to be a trauma informed lens that needs to be there when working with them. We can't be working with them from a very, very behavioral perspective that, this behavior is what I do a functional analysis of, and I look at it from that perspective only. Rather, it needs to be from a trauma-informed lens. And like the factors that the case formulation was talking about, there needs to be a component of interpersonal therapy that needs to come around. Communication skills, the stress tolerance and emotional regulation. But most importantly, positive resource building, which is also parallel to, similar to trauma lens, trauma informed lens, where actually the positive resources are limited, and how can we increase positive resources? And it's an interesting thing to see that a lot of time adolescents during the adolescent period engage in self harm much more, and those same adolescents, when are able to connect with their own good parts, or when they are able to achieve something or become more purposeful, their self harm tendencies reduce also. So positive resource building is very important. And yes, what is the self harm hypothesis? Where is it coming from? So that all these things together will be actually important for us to manage the self harm here. Two most important skills that we need to kind of work on are regulation of social, like helping them to regulate their social situations, because it is a lot of times the shame and the guilt in social situations that, the that kind of predisposes or acts as a precipitating factor for this act, as well as, so one is your reaction to me, another is my reaction to this. So the regulation of my own affective experience also plays an important role, and skills around that needs to be developed. Therefore, as a therapist, so these are some things that we need to understand. But as a therapist, therapeutic relationship is the most important, tool that, ground that we stand on. And if our eyes are not ready to see it from that perspective, then we won't be able to help them. So we need to have that kind of a vision to help them from that perspective. So therefore, one of the tricky issues is, how do you react, or how did others react to this experience of a client? If there was, and a lot of times parents are in shock and panic. When there is that panic and shock, it tends to kind of reinforce the behavior, because it's kind, there is a behavioral principle that kind of plays around over there. That if there is shock and panic, it tends to reinforce. If there is denial and mocking, but then you're doing this for attention, it kind of further plays into their low self-esteem. If it is control and punitive, because I would like it to stop, and there is some kind of negative rather than a positive connection, there is a negative approach to it, then
it further increases negative emotions. And I'd like you to take to this idea of, how these reactions actually tend to maintain the cycle. So there is a high negative emotion already that the individual has, and these kind of reactions increases that negative emotion reaction. And then there is engagement, which is to reduce this negative reaction, and there is a release or relief that the client feels. So therefore, it becomes slightly difficult also. How do you approach it? Do we need to also look at a lens of behavioral addiction over here? Because there is which also comes from, again, from a trauma lens. Behavioral addiction also is how do you connect with the individual's low self-esteem and look at self-efficacy and bring about more efficacious, how the client can feel more efficacious, more purposeful in their daily activities as well. So therefore, one of the key components that we as therapists need to work on is not normalize it, but not really be in a shock also. Understand and connect with the client. So it's kind of a little tricky situation because you're not really wanting to normalize it so that it is okay, but at the same time you don't want to kind of say it's not okay, and understand that there is this experience that the client is having. So how do we work around validation of the emotion, not the act, but the emotion, and self-acceptance to reduce shame and embarrassment? The components that work in are relational components than technique components. Relational components go a long way when working with children or adolescents with NSSI also. Even young adults with self-harm, with NSSI, there is relational concept that works much more than actually the techniques that you use. So the therapist's relational aspect will make them connect with you better and the chances of you intervening. Because if the door is closed, you can't enter that. So to open that door, relational aspect comes into play. And therefore, one of the relational thing is to provide that space for disclosure because they don't share it openly. If they start sharing it openly, there is less of shame and embarrassment and guilt that kind of is there because there's somebody listening to them also. There is space for emotional healing and behavioral change that comes in. So positive therapeutic relationship lays the ground, specifically in NSSI. This is primarily from NSSI perspective, where you're modeling the mindful acceptance of difficult feelings. We're encouraging orientation towards a little bit of towards values and trying new behaviors. So purposefulness to be added, genuine connection, reduce of loneliness, social skills, how they relate with the client actually, how they relate with the, like I can share with specifically this one case. She was like, she started kind of relating to the therapist and would talk to the therapist in a different way than she would talk to everybody else. So, and slowly it was seen that that kind of generalized to other people also because she was more regulated in the session. She was more regulated in the session, so she got that example of how regulated spaces can also look like and how that regulated spaces then can be tried outside the therapy space also. So encouraging efficacy and ability to improve life. These are some of the evidence-based approaches that have been found to the electrical behavior therapy because of the emotional regulation component that is there. There is mentalization-based therapy for enhanced self-understanding, cognitive behavior therapy to target maladaptive thinking. If there are specifically cognitions associated with those specific experiences of childhood, then to work around that from cognitive perspective, but also acceptance and commitment therapy to promote acceptance and value-based livings. I'm going to kind of skip this due to a lack of one needs to understand that for a
effective treatment, we need to include family. And like I said, that the um, reactions of the family or the connections with the family also play a very important role here, and that needs to be worked on. Individual skills training, comprehensive case formulation from this individual perspective, because self-harm hypothesis changes from individual to individual also. So take that case approach, case formulation approach here, and integrating multiple strategies rather than one strategy. So far, even if there are evidence based, there is still a high relapse rate, and about 40 to 60% continue to self harm. When they stop, it's also a little bit of a question and a puzzle, because it's seen most in adolescents and young adults, and sometimes in the adulthood, this stops. Is it with achievement that it stops? Is it with brain development that it stops? Is it because of other things? But there is a reduction that can be done even in adolescence and young adult phase. So that part of full recovery is slightly questionable here, which we need to understand, and we need to continue our researches to find out what can work best with them. 2 decades ago, rather, when I was in my student days, no harm contract was the way to go. But currently, no harm contract is showing that it's not very effective, rather, sometimes tend to rupture the therapeutic relationship. So instead of going into no harm contract, go into safety planning. Safety planning, helping them actually learn the first aid methods also that can help them, also help them with different alternatives. There are a lot of people who have tried some creative art therapy approaches, where instead of cutting, because the red color makes them see, feel something, using the red color markers for them, working with different temperatures to kind of feel something, because they want to they want to feel that numbness or something. So using the DBT approach from that, the temperature approaches that are there, tip skills that are there. So those also tend to work. And a collaborative safety plan will look like helping them work with harm reduction strategies rather than no harm, alternative coping mechanisms, and activation of support networks. Some ethical considerations in practice, because when we are working with them, we are also carrying their emotional load with us. So maintaining confidentiality, but while ensuring safety. Safety, I think we all understand, safety trumps confidentiality. So safety first. Balance between autonomy and duty to protect, which is very important, and address clients' counter transference, because as clinicians counter transference, because when we are working with them and there is a relapse, you also kind of the narrative that one narrative they carry for themselves, another narrative as therapists you carry for them. If as therapists we think this is not going to change, then this is not going to change. So what is the narrative that you're carrying? But take your counter transference to supervision, work around the burnout that is there when working with people who have self-harm tendencies, because they do bring a lot of emotional space for you, and demands a lot of emotional labor from you. They will rather demand more emotional labor from you also. So how do you navigate that experience? Work with your supervisors on that also. In terms of relapse and recovery and relapse prevention, like I said, recovery is a little questionable, but there is something that we still need to work on. Identify early warning signs, develop, you know, develop a plan with the triggers, coping strategies, and alternatives. Focus more on resilience and positive resource building, and nice guidelines that says CCT, which is compassionate assessment. So not a very interrogative assessment, rather a more compassionate approach to assessment, collaborative safety planning, and tailored psychosocial interventions is what we know so far about working with NSSI. And with that, we end this symposium. Thank you very much for being such a great audience.
It's a
wonderful presentation. And as you know, it's more like, clinical model, what they are doing in OPD setting. No hospital, but yes, as a clinical psychologist, they are intervening. So that limitation is always there. Like as I'm in United States and what I see there, any kind of such patients, suicidal, psychologists have power to refer them to hospital directly from their private clinic. But such situations and the priorities like it's differing culture to culture, country to country, and even psychologists are not that powerful here in India because then medical model comes and a ethical model comes and magistrate comes and lot many things. So keeping those things aside, what they are doing is wonderful intervention as a teaching model and it will give wonderful learning. So keeping this in view, now the symposium is open for questions, maybe 2 question, 3 question, 4 questions, though lot of things they have said. So please, anybody has to ask some question, please go ahead. Yeah, no, but it's still 2 question. Yeah, please go ahead.
Excellent presentation. Thank you very much for taking us through NSSI. One question I had, I also work with adolescents with this. I've also seen peer pressure. So in classes, we've seen in schools, one, in the group, one kid would have done this and they speak in that small clip and that model behavior. So how would you look at that? The social peer pressure.
So, like I said, that the self-harm hypothesis that kind of comes around here. That what is the intention? So, when we are saying intentional self-harm, yes, but it is also in that respect, it's also intentional identity because my friends are doing this. I should, I will also be trying to identify so that I can be part of the group, or I emulate the same emotional experience as them, right? As well as one thing that is there is because one child is doing, that child is getting attention in the class, right? So that therefore this is not as simple as it looks. It's quite tricky in that phase, and therefore our approach to it also needs to be a little bit more reflective. We need to take that step behind to see actually the self-harm hypothesis here and then develop our plan accordingly. So that'll be my answer to that.
One more, if you someone, otherwise we can close this session. So thank you very much. And it was wonderful session.
Thank you, sir. Thank you, ma'am, for this wonderful session. We will move to the next session. And since this was a CRE session, I have shared 2 Google Form links for both the presentations. Kindly fill both the forms for you to get the CRE points. Okay. So now we'll be moving to the next symposium, that is Symposium 3 as per your program schedule. Which is titled Comprehensive Geriatric Assessment, a Biological Approach to Cancer. Where is Angela?
हाँ ले लो आओ आओ
सर ऐसे कंप्लीट चल रहा है ना अभी इनका होगा उसके बाद ठीक है तो है सब धीरे चल रहा है हो गया शुरू में ही रोड हाँ, दो तीन So we will be starting with the third symposium, which is titled Comprehensive Geriatric Assessment, a biopsychological approach to cancer. Okay. Before we start with the session, I would like to introduce and invite the chairperson for this session, Professor Dr. Anand Kumar sir, on stage to chair the session. So please come on stage. Professor Dr. Anand Kumar sir will be chairing the symposium on comprehensive geriatric assessment, a biopsychological approach to cancer. Professor Anand Kumar is a distinguished and internationally recognized professor of psychology. His area of specialization includes clinical, health, and sports psychology. He is a former HOD of the Department of Psychology at MG Kashi Vidyapit, Varanasi. Professor Anand Kumar has been teaching in MG Kashi Vidyapit since 1978. He has been recipient of many prestigious national and international honors and awards. Best Speaker Award in the 10th World Congress of Social in 1983 at Osaka, Japan. Life Fellow Award by the World Association for Social Psychiatry and Man of Achievement Award by the International Biographical Center, Cambridge University, England. He has been visiting professor at Goethe University, Frankfurt, Germany. Professor Anand Kumar has chaired scientific sessions, delivered keynote addresses, guest lectures at international conferences and academic organizations in various different countries. He has been president of Sports Psychology Association of India between 2002 to 2006, chairman University Academic Committee, and acted as official sports psychologist of Government of India at Seoul and Sydney Olympics. More than 100 research papers have been published in accredited international and national journals in his credit. We welcome you, sir. And I would kindly request Dr. Sonia Poor, professor at IBAS, to kindly felicitate sir for chairing this session. Now, I would like to call upon stage the two speakers for the symposium now, Ms. Angela Paul and Ms. Srijani Chakraborty. Please come to the stage. Ms. Angela Paul is currently serving as Scientist B. And this take the seat. Ms. Angela Paul is currently serving as Scientist B at DRDO, posted at the 5 Air Force Selection Board, Guwahati. She is pursuing her PhD in clinical psychology from the Institute of Psychiatry, Kolkata, and holds an MPhil in clinical psychology from RIMPAS, where she was the university topper. Alongside her work in military psychology, she has a deep interest in engaging with individuals at the grassroots level with a focus on applied and community-based psychological practice. And sir, if you could kindly felicitate Angela Paul. The next speaker for the symposium is Ms. Srijoni Chakraborty. She has done a master's in psychology from Venerable Sindhu University. Currently, she is working as a research intern in the geriatric department at Calcutta Medical College and is a psychology teacher in Delhi Public School, Beauty Park, Kolkata. Her interests lie in health psychology, geriatric mental health, and educational psychology. So, if you could kindly felicitate Ms. Srijoni Chakraborty. So, without further delay, we will start with the symposium. Over to you. I want to lower. Just the maximum. This is not a talk about disease. It's about people living meaningfully with a disease. Good afternoon. I'm Angela, and with me I have Srijoni, and our topic is comprehensive geriatric assessment, a biopsychosocial approach to cancer care in older adults. India's aging population is growing rapidly. By 2050, nearly 1 in 5 Indians will be above 60 years of age. This demographic shift coincides with a rising cancer burden, where over half of all new cancer cases occur among older adults. Yet, in most settings, clinical decision making still relies largely on chronological age and disease pathology. Such an approach misses the vast variability within older populations, which is shaped by comorbidities, cognition, function, nutrition, social support, and psychological resilience. The comprehensive geriatric assessment, developed first in the 1980s, offers a structured way to capture this complexity. It is a multidimensional, interdisciplinary evaluation designed to determine an older person's medical, psychosocial, and functional status, thereby guiding treatment and care. In India, it is implemented through the comprehensive primary health care under the National Program for Healthcare of the Elderly, under Ayushman Bharat Initiative, and adapted by the Ministry of Health and Family Welfare to suit the Indian public health context. The CGA adopts a biopsychosocial lens, recognizing that clinical outcomes in older adults depend as much as on psychological adaptability and social environment as on biological health. Now, coming to the components of it, the biological component, this dimension covers everything that happens within the body. Our genes, neurochemistry, immune system, physical health. It includes factors like comorbid illnesses, hormonal changes, metabolic or endocrine disorders, and the effects of medications. Aging itself brings physiological changes like reduced muscle mass, slower metabolism, altered drug metabolism, all of which can affect how a person responds to disease or treatment. In the case of geriatric cancer, for example, comorbidities like diabetes or hypertension or even subtle neurological changes can significantly shape both the progression of illness and the person's ability to tolerate chemotherapy or radiotherapy. Coming to the psychological component, it includes elements like personality, temperament, coping style, emotion regulation, self esteem, and resilience. Our belief, expectations, and past experiences all shape how we perceive illness, how we respond to stress, and how motivated we are to engage with the treatment. For instance, two elderly patients may receive the same diagnosis, but One may approach it with acceptance and adaptive coping, while the other may spiral into hopelessness or denial. The difference often lies not in the severity of the disease, but in the psychological framework, the person's mindset, coping resources, and emotional resilience. Trauma, loss, or chronic stress can also leave deep imprints on how a person experiences the physical symptoms. Then comes the social component. This domain reminds us that no one lives or suffers in isolation. Family relationships, social networks, economic conditions, and cultural values all have profound effect on health. Social support can serve as a powerful buffer against stress and depression, while social isolation or financial strain can worsen both mental and physical outcomes. In many Indian contexts, for example, older adults rely heavily on family caregivers, and caregiving itself becomes a complex psychosocial system, shaping not just the patient's well being, but the attitude towards the illness, the family's mental health, everything. Factors like socioeconomic status, education, access to healthcare, cultural beliefs about aging and death all shape how people seek help, adhere to treatment, and cope with uncertainty. Now, what's truly powerful about this model is that these three systems, biological, psychological, and social, are interconnected. They don't work in isolation, they continuously influence one another. A biological change can trigger a psychological distress, which can then alter the social functioning. Conversely, strong family support and a positive outlook can improve immune response, treatment tolerance, and even survival outcomes in the patient. The CPHC CGA operationalizes this philosophy itself in the Indian context. Now we come to the CGA itself, the sections and components within it. First, we take the basic details of the patient to map the context of care. This section focuses on registration, identification, and socioeconomic information, including living arrangements and caregiver details. This forms the contextual backdrop against which the older person's health and functioning can be understood. Social isolation, financial dependency, and limited literacy are frequent determinants which delay treatment seeking, poor adherence, and distress among elderly cancer patients. Recording these details systematically ensures that assessment begins not at the disease level but at the person level. This allows the care team to visualize the individual support network, environmental safety, and potential barriers to the continuity of care. Such contextual information also informs communication strategies, expectation management, and engagement planning, areas where subtle psychological understanding becomes crucial for a successful intervention. The next section is about the history taking of the patient to build a narrative of health. A comprehensive history goes beyond the symptoms to explore how the individual lives with and interprets illness. In CPHC CGA, history taking includes presenting complaints and duration, past medical and surgical history, drug adherence, substance use, nutritional patterns and appetite, family, social, and spiritual life, and personal routines and environmental conditions. The process allows the clinician to reconstruct the narrative of aging, revealing the interaction between physical disease and life circumstances. In oncology, for example, symptoms can often reflect complex biopsychosocial interactions. Fatigue, appetite loss may result from metabolic changes, but can also indicate grief, loss of control, or loneliness. Pain may arise from tumor effects, yet worsen with anxiety and isolation. Sleep problems may stem from treatment, but persist due to fear or intrusive thoughts. Weight loss or poor treatment adherence may reflect both physical decline and emotional distress. Thus, history taking becomes the first opportunity to identify the psychosocial stressors that modulate the physical health. When approached with curiosity and respect, this stage naturally promotes rapport and trust, which is essential for accurate assessment and adherence to care. The next section enables rapid screening like frailty, falls, immobility, incontinence, and chronic illness. It covers screening for geriatric syndromes, other age-related problems, and functional assessment. Evidence indicates that functional status is the strongest predictor of treatment tolerance and survival in older adults.
outweighing the chronological age. Functional loss, however, is rarely only physical. It has profound psychosocial effects threatening autonomy, identity, and confidence. Recognizing these layers allow for care planning that preserves both safety and dignity. Such brief screenings can reveal early signs of mood or cognitive changes, making the process both preventive and therapeutic in nature. So this is how the 10-minute comprehensive screening goes like. First, we screen for the geriatric syndromes, which generally includes memory, depression, falls, urinary incontinence, and memory recall. Then we screen for other age-related problems like vision, hearing, weight, constipation, and insomnia. And then there's the assessment tool for activities of daily living, where there are 6 points based on which the assessment is done. The next section is on the physical examination. Biological findings must be interpreted through psychological and behavioral lenses. Physical symptoms often mirror emotional burden, anxiety, or neglect. Clinicians are encouraged to read the body as biographical text, not just a biological specimen. This section includes general examination, head-to-toe examination, and systemic examination. General examination covers vital parameters like height, weight, BMI, waist to hip ratio, temperature, pulse, respiration, BP to assess overall physiological stability and nutrition status. Then the head-to-toe examination includes observation of appearance, nutrition, hair, eyes, oral cavity, neck, chest, abdomen, skin, nails, limbs, and visible signs of aging. And the systemic exam assesses joints, spine, respiratory, cardiovascular, abdominal, and neuromuscular systems, evaluating movement, tone, gait, and functional capacity. These findings, if interpreted contextually, often tells a story that extends beyond physiology. This approach reinforces the biopsychosocial reading of the body, understanding physical signs as outcomes of the interaction between disease, emotion, and environment. For example, a low BMI may indicate malnutrition, but equally reflect poor appetite due to depression. Limited mobility may stem from arthritis, but may also represent inactivity secondary to social withdrawal or learned helplessness. This approach reinforces the biopsychosocial reading for understanding the physical symptoms as the outcome of the interaction between disease, emotion, and environment, as already discussed. The next section is a syndrome-specific toolkit. So once the initial vulnerabilities are detected, then we go for targeted assessment for the specific geriatric syndromes using standardized tools. So memory loss and cognitive impairment is assessed using the GPCOG and then recall and orientation tasks. It helps to understand the treatment adherence, autonomy of the patient, caregiver strain, and daily functioning of the patient. Then depression is assessed using the geriatric depression scale. This helps to understand the first person's survival, coping mechanisms, level of motivation, and overall mood. Fall risk is assessed using the FR evaluation form and timed up and go tests. This is related to the patient's safety, confidence, and independence. And then incontinence is also assessed and managed, the clinical implications being the patient's hygiene, dignity, and social withdrawal. So all these syndromes are interconnected, not isolated. Cognitive decline, depression, and frailty often co-occur in older cancer patients. Around 30 to 40% present undiagnosed depressive or cognitive issues. When systematically assessed, these factors significantly influence treatment planning, caregiver support, and long-term outcomes. Hence, incorporating these evaluations within CGA ensures that the care is comprehensive, anticipatory, and person-centered. Then the next section is the caregiver and elderly abuse assessment, which is a crucial component designed to identify signs of stress, neglect, or mistreatment within the caregiver relationship. The caregiver abuse assessment explores the helper's emotional state, behavioral responses, and ability to manage the elderly person's need, with even a single positive response suggesting potential risk of abuse and scores above 4 indicates significant concerns. The Elderly Abuse Suspicion Index complements this by screening the older adults for experiences of physical, emotional, financial, or neglect related abuse. It assesses dependency, restriction of autonomy, verbal humiliation, coercion, and physical harm. Together, these tools enable early detection of abuse, foster preventive intervention, and reinforce the biopsychosocial understanding that caregiver burden, emotional exhaustion, and systemic neglect often intertwine to compromise the dignity and well-being of the older adults. So this is how the caregiver abuse assessment looks like. It has 8 items in total. Even 1 is indicative of abuse, and a score greater than 4 is suggestive of a higher risk of being abused. And then the elderly abuse suspicion index is there as well. This again has 6 items. The last one is the one we asked to the doctor and not the patient. The next section is the CGA report, from data to decision. So here we synthesize findings from all domains into a concise multidimensional report. It provides a summary of medical, functional, and psychosocial findings, identification of modifiable risks, recommended interventions and follow-up plan, and a record for multidisciplinary communication. This document serves as the patient's functional and psychosocial health profile, informing decisions regarding chemotherapy tolerance, rehabilitation needs, and family engagement. Studies show that CGA-informed management alters treatment plans in 40 to 60% of older cancer patients, often improving tolerance and outcomes without compromising on the efficacy. The report thus becomes an operational bridge between oncology, geriatrics, rehabilitation, and mental health, ensuring continuity of care and a shared understanding. So how do we integrate the CGA in cancer care pathways? To strengthen the CGA in India, it is important that the scalability is taken into consideration. First, the multipurpose workers conduct screening and community follow-up at the primary care level. Then, at the secondary care level, clinicians perform detailed medical and cognitive evaluations. Then, the tertiary care level, where oncology and psychology collaborate for a tailored treatment planning. And finally, psychosocial rehabilitation and caregiver support is provided at the community level. So this ensures that the care is equitable, inclusive, and continuous across the health system, and operationalizes the biopsychosocial model in everyday oncology practice. So some implementation and research priorities. To strengthen CG in India, attention must be given to training community workers and clinicians in geriatric and psychosocial assessment, developing culturally adapted cognitive and mood tools in local languages, integrating CGI outcomes into routine cancer board discussions, building longitudinal research on frailty, resilience, and quality of life among elderly cancer patients. Emerging work in psychosocial oncology also suggests that emotional acceptance, meaning making, and perceived social support act as mediators of resilience in older adults. Themes that can be directly incorporated into CGA-based intervention planning. So presently, we are undertaking CGA studies at the Department of Geriatric Medicine, Calcutta Medical College, focusing on its implementation and also as a part of psychotherapeutic intervention and palliative care programs. We're administering additional standardized tools alongside the CGA to gain a deeper understanding of the psychological challenges faced by geriatric cancer patients. The tool has also been translated into Bengali, and validation studies are currently underway to enhance its accessibility at the grassroots level. Given that a large proportion of our participants belong to the low socioeconomic and low literacy background, our efforts focus on improving the tool's applicability for them. Based on CGA findings, we are further extending support to psychoeducation, counseling, and therapeutic interventions tailored to the patient's specific needs. As we have seen, the CGA is far more than a diagnostic checklist. It's a structured, deeply human approach, one that recognizes how health in later life emerges from the interaction of multiple dimensions. It blends scientific rigor with human sensitivity, recognizes the older adult as an ecosystem of interdependent systems. It facilitates care that honors autonomy, dignity, and emotional well-being. It strengthens collaboration among oncologists, psychologists, social workers, and caregivers, and reflects a shift from treating the disease to understanding the person who lives with it. Ultimately, it's not about adding years to life. It's about ensuring that life, even in its later years, retains coherence, dignity, and meaning. So that leaves us with the question that what would change if a cancer patient's journey began with a life story and not a lab report? So, the next presentation, we will be discussing about some real world experiences of working with geriatric cancer patients, emphasizing the applicability of the CGA at the grassroots level and resource limited settings. Handing over to Srijani. Good afternoon, everyone. I'm Srijani. Now that you've got a brief understanding, a very clear understanding of how the structure and the components of CGA are, I would like to take it further and give you some practical scenarios and hands-on experience on working with such geriatric oncology patients in hospital settings. Let's talk about Mrs. X. She is a 78-year-old lady currently diagnosed with breast cancer. Her family was devastated, but they remained hopeful and immediately took her to the hospital. However, as her treatment started, she began to face certain problems that no one warned her about. Her body, which was already weakened with diabetes and heart disease, struggled with chemotherapy. The medications made her dizzy, and she faced difficulty with maintaining body balance. She also gradually started losing her appetite and began having trouble remembering things. Her oncologist helped her in every possible way by focusing on her cancer, but no one seemed to focus on the fact that her age and other health related issues made things more complicated. Cancer in old people is quite different from the younger patients in terms of how the body responds to treatment, how it progresses, and also how it affects the quantity. So I'll continue and we shall resume with the presentation to the next time. Okay, sure. As I was mentioning, cancer patients in older adults is quite different from how it is with the younger ones in terms of how the body responds to the treatment, how it progresses, and how it affects the quality of their life. Aging brings certain physiological changes that can alter the effectiveness of the treatment, such as chemotherapy, radiation, and surgery. often making them more challenging to tolerate. Also, elderly patients may have a slower recovery rate, increased susceptibility to side effects, and a heightened risk of complications. With the progression of late adulthood, patients also start losing hope for recovery. In my experience of interacting with several geriatric oncology patients, when I use the CGA, especially the geriatric depression scale part of the CGA, to ask them how satisfied they feel in their life, or if they are afraid that something bad is happening to them. ये वाला, ये वाला. Okay, let's begin. Let's continue. So, as I was saying, they start losing hope for recovery. When, in my experience, when I use the GDS, the geriatric depression scale on them, and to ask them if they are satisfied with their lives or are they afraid that something bad is going to happen to them, I often get answers like, "What else can happen at this age anyway?" This feeling of giving up can be explained by Seligman's learned helplessness. So what is this? It when people face difficulties like in difficult situations, be it loss, illness, dependence, again and again, they may start to believe that nothing they can do can change what happens. As a result, they just stop trying, they lose motivation, and may become depressed. The health belief model, the HBM, also helps explain this pattern of behavior. Many elderly patients underestimate the benefits of the treatment. They have thoughts like, it won't make a difference now, or I'm too weak for chemotherapy. Their health decisions often hinge on perceived severity, susceptibility, and self efficacy, beliefs that can be reshaped through psychoeducation and counseling. As the global population ages, older adults represent a large population of cancer patients. Such patients require specialized care that not only are addressing the complexities of cancer treatment, but also considers the broader physiological and psychological challenges. Along with cancer, they are having other comorbidities as well, like diabetes, cardiovascular disease, arthritis, and so on, and are more likely to be already on multiple medications, which can complicate the cancer treatment. Hence, CGA represents a paradigm shift from a disease-centered to a person-centered oncology. It challenges the one-size-fits-all approach and ensures that older adults receive not only effective but also compassionate, individualized, and effectively balanced care. This shift is deeply aligned with the biopsychosocial model, which emphasizes that health and illness arise from an interaction of the biological, psychological, and sociological dimensions. CGA uses this model in oncology by integrating the medical assessment with mental health and quality of life evaluation. CGA's role in addressing diet and addiction. Tobacco and diet are among the leading causes of cancer in India. Research says that tobacco use accounts for nearly half of male cancer and one-fifth of female cancers, with chewing forms contributing heavily to oral cancers. At the same time, rapid change in the diet from like we used to have a traditional plant-based diet before, now with processed food and unhealthy fats, the rate of cancer has increased in the digestive tract and breast. The comprehensive geriatric assessment systematically brings these lifestyle risks into focus. Through its mini nutritional assessment, MNA, that the previous presenter has already mentioned, CGA evaluates their appetite, recent weight loss, dietary patterns, identifying the malnutrition early so that the diet plans and supplements can be introduced before the treatment begins, Thus, it improves the treatment tolerance, recovery, and quality of life. It also explores addictions like tobacco and alcohol use, not just as risk factors, but also behaviors shaped by stress and loneliness. Using Lazarus and Folkman's stress appraisal coping model, we can see how patients' appraisal or perception of cancer, is it as hope, threat, or harm, or challenge, determines their coping style, whether avoidance, denial, or active problem solving. By using and identifying these maladaptive emotion focused coping, like smoking and drinking, we can introduce healthier strategies through counseling. Importance of focusing on mental health in geriatric oncology patients. Now, in everyone who's present in this room, we are all from different institutions and are from different places. We have different levels of expertise. But one thing we all of us have in common, not just in this room, but everybody in this conference, is that we all understand the dire importance of mental health. And we often witness how it often goes avoided by other professions and other settings. Similarly, mental health plays a pivotal part in the lives of older adult cancer patients, yet it often gets overshadowed by the medical aspects of treatment. In our work, we have seen older cancer patients face not only physical pain and side effects, but also deep rooted psychological challenges, anxiety, depression, helplessness, loss of purpose. According to the self determination theory by Ryan and Desai, human motivation depends on three basic psychological needs: autonomy, competence, and relatedness. In geriatric oncology, all these three aspects are often threatened. Autonomy is compromised by medical dependency, competence by cognitive or physical dependency and decline, and relatedness by social isolation. Restoring these needs through supportive therapy enhances engagement and psychological resilience. Speaking of social isolation, let me give you a few patient anecdotes of the people of the cases I have witnessed through my experience in conducting the CGA. This one time, there was this elderly lady. I was conducting the CGA with her, and she started, having tears in her eyes, and she was saying, like, she was first asking me, "Ma'am, can you just reassure me whether is cancer an infectious or contagious disease?" So of course, I cleared out her confusion. I said, "No, that's not at all true." So then she started crying and said that, my family wouldn't let my grandson come near me. My son, my daughter-in-law, they're not letting my grandson come near me after I was diagnosed with cancer because they mistakenly believe that cancer is contagious. So this story reflects not only her loneliness, but also the lack of awareness and stigma that cancer still carries, especially in the rural and semi-rural areas. There was another patient, a 64-year-old woman. She was from Hooghly. She spoke about how she withdrew from social gathering after losing her hair during chemotherapy. So there is an assessment called the spiritual and the social assessment where we ask, like, do you go out? Do you socialize, meet people? So that is where she said that she used to be very social, but now she left doing all that because she started losing all her hair. She got very, her confidence is just gone and she just doesn't go out. Even though she was given a wig, she said that it made her feel unnatural and uncomfortable. Also, she felt very emotionally drained by the people's constant sympathy. Their looks and questions became daily reminders of their illness. Her experience showed us how physical, visible changes can damage self esteem, confidence, and social connectedness. Another story, there was a retired chemistry professor, and that story really stayed with us. So during his CGA assessment, we conducted the mini mental status examination, the MMSE. And one of the tasks in that test is to draw two overlapping pentagons. And he tried several times but couldn't do it. His hands started trembling, and eventually he broke down, saying that although the image looked very familiar, his mind just would not cooperate. He later told us how painful it felt to realize that the very skills that once defined him were slipping away. His son, who was there with him, standing nearby, he just left the room because he was very unable to watch the father's struggles. This highlights how neuropsychology Domains such as memory, attention, executive functioning, visuospatial ability are often compromised in older adults and may further decline with chemotherapy. The MMSE here functions not just as a screening tool, but also as a broader part of the neuropsychological assessment battery that helps identify cognitive impairment. This shows us how cognitive decline, even mild, can cause immense emotional damage, not just for the patients, but for their families as well. And it reminded us that behind every cognitive test score is a human story of loss, identity, and dignity. What's more important to understand is that many of our patients come from low socioeconomic and rural backgrounds, where access to healthcare, education, or even basic facilities like electricity, toilet is limited. With little awareness and very few resources, they often build their lives on compliance and silence, believing myths, hiding their illnesses, or even accepting discrimination. From a cultural psychology perspective, this is also influenced by India's collectivist culture, which emphasizes interdependence, family harmony, respect for elders. But this also often means that major health decisions are often taken by younger family members. While this can offer strong emotional and practical support, it can also unintentionally reduce the patient's sense of agency, especially when they feel that they shouldn't be disagreeing or expressing their concern. So, family based psychoeducation becomes very essential here, not only to inform caregivers, but also empower the patient's voice within the family system. Psychologically, we often see what Erik Erikson described as the final stage of development: integrity versus despair. Here, at this age, the older adults often reflect on their lives and ask, have I lived well? Have I left things unfinished? Some patients accept their situation with calm and acceptance, saying that they have lived truly and are at peace. While others, however, they express regret and despair, feeling that time has run out before they could fulfill their responsibilities or dreams. This inner conflict often surfaces more intensely while facing a diagnosis like cancer. At this stage, certain interventions like meaning centered psychotherapy help patients reconstruct a sense of purpose, while ACT or acceptance and commitment therapy fosters psychological flexibility, encouraging them to accept their distress while pursuing value life goals. Again, CBT or cognitive behavioral therapy can further address the body image issues, anxiety, and existential fear. To ground these observations in data, we have conducted a cross-sectional, center-based exploratory study using the comprehensive geriatric assessment on elderly cancer patients receiving treatment. Our study population included the geriatric oncology patients aged 60 years and above visiting this oncology department of Calcutta Medical College, Kolkata. We used purposive sampling to select the patients who met the inclusion criteria, that is, individuals diagnosed with any type of cancer, currently undergoing or planning to undergo for treatment, physically and cognitively capable of completing the assessment. Patients with severe cognitive impairment, terminal illness, or inability to participate in the study were in the excluded criteria. In total, 50 elderly patients participated in the study. Each were assessed across multiple domains of CGA: medical, psychological, functional, nutritional, and social. As the graph shows, which is emphasizing more on the psychological perspective, we have found that 46.767% exhibited symptoms of depression, 17.78% has fall risk, 20%, 35%, and 11.11% suffer from incontinence, memory loss, and loss of daily life activities, respectively. So, by using CGA, we uncovered these hidden issues: the undiagnosed depression, dementia, social neglect, financial struggles, lack of family support. Now, once we see the full picture through the CGA, we can now tailor interventions, whether that means counseling, nutritional advice, medical adjustments, or just simply being there, to give them a space to express their feelings. Some research on CGA and its importance in geriatric oncology. In India, very limited, but very significant research highlights the importance of CGA in cancer care for older adults. Bora et al. In 2013 applied CGA to assess medical, nutritional, psychological, and cognitive domains of elderly cancer patients, revealing impairments in activities of daily life and cognitive domains and poor scores in physical, psychological, and social well-being. Prabhash et al. 2020 at Tata Memorial Hospital found that 98% of patients aged 60 and above showed vulnerability in at least one geriatric domain, with a high risk of treatment related toxicity due to factors like polypharmacy and frailty. Psychological health plays a very critical role here as well. Borza et al. Demonstrated that higher depression score in the GDS 15 were linked to increased mortality in older cancer patients, emphasizing the need for integrated psychosocial care. Overcash et al. 2019 and the Society for International Oncology in Geriatrics, SIOG, recommended CGA as a foundation for individualized treatment planning, adaptable across oncology settings. American Society of Clinical Oncology, ASCO, also endorses assessing key geriatric domains like social support, cognition, nutrition, and depression to guide safer treatment. Despite this, geriatric oncology remains underdeveloped in India. Survey shows that over 70% of oncologists do not use any formal assessment tools, and many remain unaware of the ASCO guidelines. And more recent findings by Prabhash et al. 2022 indicate below average quality of life and persistent symptoms such as fatigue and appetite loss worsened by financial strain. This gap calls for a greater integration of psychology, clinical psychology, within oncology, using the standardized assessments, evidence based therapy, and culturally sensitive approaches rooted in the biopsychosocial framework. And these gaps underline a pressing need for research and clinical integration of CGA and psychotherapeutic interventions tailored to elderly cancer patients in India. So, when we talk about treating older adults with cancer, CG reminds us that our goal is not only to prolong life, but to preserve meaning, dignity, and quality of life. It helps us treat not just the cancer, but the whole human living with it. Thank you.
Yes, it was really a very wonderful session, and both Aldida and Sijini have presented very well details about biopsychosocial model, which was formulated by George Angel in 1977, and it is widely used in health psychology, and cancer or oncology is already a field of health psychology. As a president of health psychology, so I know it very well. So it was very wonderful presentation. You have covered all the assessment sessions, all the assessment techniques, tools, and all details. How to assess these senior or aged cancer patients, and these practical your experiences are really very wonderful, and you carry on and have more good results. Thank you.
I have a question.
Yes.
Yeah. Here you have done the spatial assessment as a component of CGA. Is it necessary?
Ma'am, hello? Hello, yeah. So the social and spiritual assessment that is done in the CGA, basically people, the older adults with a disease like this, they often lose hope for, they have a very problem, existential crisis. They often have very little hope about life and the scope beyond that. So they often go through the path of spirituality and praying, and they take that as a coping mechanism to overcome that. So that is why we use this particular assessment to understand their coping mechanism and how they're dealing with a situation like this. Thank you.
Thank you.
Else? Any question? Okay, thank you. We are closing this.
Hello. Thank you for such a thank you for such an insightful presentation. Now we'll be moving on to the next symposium on the topic that is cultural competence in clinical assessment and diagnosis of behavior addiction.
Now I would like to introduce our chairperson for this symposium, that is Professor Kaptan Singh Sengar. He's a distinguished professor in SDT University with over 38 years of experience. I would like Dr. Bhavna Mukund to felicitate Sir. Now I would like to introduce our speakers. Our first speaker is Dr. Ritvik Kashyap. He's an associate professor and head department of clinical psychology at GSS Medical College and GSS Hospital, Mysore. He has done his PhD from University of Mysore, MPhil Clinical Psychology from Swikar Academy of Rehabilitation Sciences, and he has also done 13 publications in national and international journals and 3 book chapters and 1 book. His areas of interest are mental health and resilience, parenting styles, and child and adolescents' mental health. Now, I would like to introduce our next speaker and would want her to come on stage. That is Dr. Trishila. She's an assistant professor in Department of Clinical Psychology, JSS Medical College, JSS Academy of Higher Education and Research, Mysuru. She has published 6 research papers and guided 24 PG dissertations. Her area of interest are mindfulness, geriatric mental health, behavioral addiction, and positive psychology. Our next speaker is Miss Ashmita Jain. She's an assistant professor in Department of Clinical Psychology, JSS Medical College. And our next speaker is Abhiram M. Ajay. He is an assistant professor in JSS Medical College. I would like Dr. Kaptan sir to facilitate the speakers. And this symposium is a CRE session.
So, good evening to all. I had been already here on the same chair earlier, so I don't think that anything need to tell. So, present topic is very important topic: cultural competence in diagnosis and assessment of food addiction in India. This is why important topic, because many time when you deal with the patient, or we can say client, forget about patient, and you are not acquainted with the language or behavior of that particular culture from where he belongs. So what you do, you count it as a pathology, something deviation from your norms. Of course, in India, it's a very difficult to be aware about all the cultures, all the languages, but as much as you can do, you must do the justice. If you are not in position to understand the language and culture, it is always better to take the help of somebody, those who are aware from that. Like I am from, I work in Ranchi. I don't know the Bangla, but whenever Bengali patient comes, I used to call to Bengali students or somebody, and I ask them to just interview, and I'm sitting here. So like that, that will give you introduction. I will tell you later how some example. So in that way, if you are not aware about the culture, about the language, about the uh, behavior being performed, rituals are being performed in that particular culture, you cannot justify your role as a therapist, as a clinical psychologist when you are dealing with the patient. So let me invite uh, Dr. Ritik to take the dais, and he will tell you about.
Thank you, sir. Thanks for chairing the session, and good afternoon, everyone. So it's a privilege to present this important symposium focusing on cultural competencies in clinical assessment and diagnosis of behavioral addiction. So we will be covering three major aspects of the behavioral addiction. One is the food addiction, one is the pornography addiction, as well as the gaming addiction. So behavioral addiction, such as the gaming disorder, gambling, internet addiction, and compulsive buying, are complex phenomena influenced not only by neurobiological and psychological mechanisms, but also profoundly shaped by socio-cultural context. So studies demonstrate that cultural mechanism factors affect how symptoms manifest, how distress is perceived, and how individuals seek help. So this has critical implications for diagnosis and treatment outcomes. So emphasizing on one size fits all model may not lead to misdiagnosis and ineffective interventions. So as Sir was mentioning, even during our intake sessions, so we may fail in really understanding the amount of distress and what is the source of those kind of distress. Where is it coming from? Whether it is socially promoted, or it is culturally promoted, or it is just an individualized psychological distress. So it is very much important for us to have a comprehensive understanding or a comprehensive mechanism which would make us culturally competent enough to understand. So the social cultural correlates of these behavioral addictions. So cultural competence it involves clinicians' ability to recognize, understand, and incorporate the cultural backgrounds, values, beliefs of the patients into clinical assessment and care. So research underscores that culturally adapted treatment programs improve engagement, retention, and recovery rates among diverse population by addressing cultural barriers, networks, and systemic biases. So in the Indian context, where the culture and the social factors influence border by border, kilometer by kilometer, so we are a multicultural country. So it would require us to have a more cultural competence to address these particular issues. So due to lack of time, I am cut shorting my opening remarks for the symposium. So I open the stage for my colleagues, Ms. Dr. Vishala D and Ms. Smita Jain and Mr. Abhiram Abhay, to take you through this presentation about how we can enhance our cultural competence. So what is it that we need to be open for while we are assessing as well as diagnosing and making the formulation for treatment plan in the three main areas, especially the food addiction, pornography addiction, as well as the gaming addictions. Open Ms. Trishala Asmita Ji for the presentation on food addiction.
Good evening, everyone. So I'm going to start off with food addiction, and I'm sure most of you might have not heard about it. So I'm just going to take you through introduction, the proposed diagnostic criteria for it, and some of the common assessments that have been used for it, cultural distinctions of food addiction, and the need for cultural competence, and what can we do about it. So just to introduce food addiction, although not officially recognized by any diagnostic system such as ICD or DSM, has been increasingly studied in the context of an addictive disorder. A meta review of 52 studies. Close it. Zoom has been downloaded. Okay.
So a meta-review of 52 studies on the validity of this construct actually found that food addiction is a unique construct. It's not the same as binge eating disorder, and it meets the criteria not just for behavior addiction, but even substance addiction. So in terms of considering food as an addictive substance, what has been found is that highly processed food with sweeteners, sugar, high sodium food, artificially flavored food, rich carbohydrates, saturated fats containing food are triggers for activation of the same neural pathways in the brain that are triggered in substance addiction. So this is now being considered as ultra processed food addiction. Yeah. So in India, food addiction was actually first conceptualized all the way back to 1967, where this was a paper that I found where it was termed as Chatorpan. So this was a case study that was published by authors Vatuk and Vatuk, where they conceptualized this disorder as an addiction to sweets and chaat to an extent that an individual becomes culturally defiant. So this local understanding was deeply rooted in social norms, where the idea was that sweets play a vital role in ritual and secular life. So this created tension between positive cultural values associated with sweets versus negative perceptions of excessive indulgence. So the idea that you are consuming something that is supposed to be used for religious purpose was considered as culturally defined. So that person was called either Chatora or Chatori, and this was actually the first study published on food addiction in India. However, recently, research has revealed that food addiction affects approximately 32% of Indian adults, as identified by using Yale Food Addiction Scale, with these individuals often experiencing higher rates of binge eating also, depression also. And it was also found that in adolescent population, food addiction is found among 14.6% of Indian students and is actually correlated with high academic achievement. So the higher academic achieving students were found to be having higher rates of food addiction. Unfortunately, in India, we've only had about 3 index studies published on food addiction, so we don't have much data yet. So the proposed diagnostic criteria that is being proposed is that you consume food in larger quantities or for longer time than intended, persistent desire or unsuccessful attempts to cut down, much time spent in related activities because of that, craving for food, failure to fulfill major roles, continued use despite social or interpersonal problems, activities given up or reduced to consume more food, use even in physically hazardous situations, continuous use despite physical or psychological problems, and tolerance. So as you can see, all the criteria are modeled on the DSM-5 model for substance dependence. The same model has been adapted to food addiction. These are the already existing assessments. So the most commonly used assessment is Yale Food Addiction Scale, which was developed by Gerhardt et al., which assesses addictive-like eating behavior modeled on DSM. We have several versions of it: YFAS, MYFAS 2.0, YFAS modified for children. These are the most commonly validated scales. We also have food addiction screener that is also developed out of YFAS only, just a brief version of it. Then we have reward-based eating drive scale, which measures food addiction on a continuous spectrum. Again, assesses the same construct, and addictive eating behavior scale, which also is a conceptualized as a continuous assessment. And it also has a two-factor model, appetitive drive and low dietary control. Why I'm taking you through these versions is that these are the current available assessments. None of these assessments have been translated or have been validated in Indian context. There are papers where they have translated items, but these translations are not freely available. So we do not know how well are these assessments being adapted to our culture. So this is actually how the Yale Food Addiction Scale looks like. I am not sure if you will be able to see it, but this is the introduction to the scale. This talks about, this survey asks about your eating habits in the past year. So if you can see, the food items we are mentioning are all based in American culture. So sweets like ice cream, chocolate, donuts, cookies, cake, candy, starches like white bread, rolls, pasta, rice, salty snacks like chips, pretzels, crackers, fatty foods like steak, bacon, hamburger, cheeseburgers, sugary drinks like soda pop, lemonade, sports drinks, and energy drinks. A lot of these items are not very frequently consumed by a lot of people from India. So obviously there is a need to modify this into our cultural context, and that also will vary region to region. So we actually need regional translations and multiple translations if we are supposed to use this scale. So some of the gaps that I found in the assessment was that the first gap is that BIFAS is a self-report scale. So what that can lead to is over-reporting of symptoms in individuals who have high dietary restraint. So actually, in a study, it was found that Indians self-report food addiction at a much higher level compared to other nationalities. So, for example, for your reference point, Chinese nationality students reported only 1% food prevalence, whereas Indians reported 30% self-reported food prevalence. So that means most Indians were perceiving their own behavior as addictive, and that might be coming from their own cultural ideas of how much food is healthy or how much food is appropriate. So you might be perceiving your own consumption, which might be normal consumption, as overconsumption, right? So these are all again cultural phenomena that we really need to look at. And another study also found this is another gap is that in Japanese population, compared to all of these food items that are listed in BIFAS, people are actually addicted to eat items like rice and sushi, which are not mentioned here anywhere. They do not really fall under, sweets or starches or salty stuff. So again, we probably need to look at what are some of those food that cause food addiction. So cultural distinctions in India that are around food addiction can be collective eating patterns and family-centered meals, religious fasting and feasting cycles. So why that is important is, let's say we are talking about individuals who we have an item called, do you suddenly lose control over eating, or have you had times when you've eaten more than required? We may answer yes based on some of the festivals that we would have attended or some of the family feasts that we would have attended, right? So that is why this context is very important. Then excessive guilt, moralization, self-control, restrictions on food waste. So very often we are encouraged to not waste food, because of which we may end up overeating, which actually might not be anything to do with addiction, but cultural value. Eating in abundance is encouraged during festivals, rituals, and guest visits. So how all of this impacts diagnosis? Inclusion of only Western food items might lead to mispresentation. Reliance on self-reported measures will fail to account for nuances such as culturally compliant overeating, and lack of culturally sensitive and well-validated skills will fail to capture cultural experiences. So I just want to take you through one case example. So let's say there's a patient named Anjali who is 29 years old. He's an IT professional living in Bangalore. And she works in a high-pressure IT job with erratic hours, lives away from family, relies on app-based food delivery, and her presenting concern is loss of control over ordering sweets and fried snacks late at night, followed by guilt and worry about weight. Now, in this case, from a Western lens, you might be tempted to think that she might be, meeting the criteria for food addiction. But actually, if you take a detailed interview, you might find some cultural context, like the food is linked to comfort and nostalgia. She's craving for her mother's sweets and festive food. The eating rituals, which are tied to stress, loneliness, and missing family meals, right? And the guilt that might be there because of the ideas around female restraint and body image, that females should not be eating so much in our culture. So culturally competent interpretation would be that we could actually diagnose this as more of emotional eating rather than food addiction, right? So just by paying more attention, the diagnosis may shift. She may also meet the criteria for food addiction, but we have to take into account all of these cultural factors as well. Yeah. So in future, we can incorporate indigenous concepts, contextualize food behavior, address stigma and social consequences, engage family and community, use an interdisciplinary approach, and use culturally validated assessment. Thank you.
Good afternoon, everyone. I'll be presenting on cultural competence in clinical assessment and diagnosis in gaming addiction in India. So let us see prevalence of internet gaming addiction. That is, in India, we can see 3 to 25%, and East Asia, we can see 10 to 20%, and Western countries, we can see 1 to 5%. So diagnostic criteria. So DSM-5 defines IGD by 9 criteria with diagnosis based on engrossing 5 or more in 12-month period. ICD-11 gaming disorder requires 3 core features, that is impaired control over gaming, increasing priority given to gaming over the other activities, and continuation despite negative consequences. So DSM-5 criteria may be overly broad and risk over pathologizing high engagement, while ICD-11 focuses on functional impairment
that is reducing false positives. So key challenges in India include the need for tools validated in local languages, the stigma of psychiatric labeling, and difficulty distinguishing cultural gaming passion from pathological use. And also adopting both systems requires cultural adaptation and clinical training to navigate differences and avoid misdiagnosis in India. So why cultural competence matters here? It is essential for accurate IGD diagnosis considering Indian family values, academic expectation, and collective norms around technology. So, overlooking cultural competence can lead to misdiagnosis and stigma in young Indian youth. So, cultural norms and stigma, Indian families always place a strong emphasis on academics and reputation. They all excessive gaming often seen as a so excessive gaming often seen as a moral failing. So stigma can delay help seeking as well as complicate the assessment. So here are the few dimensions we can see across India, East Asia, and Western countries. So cultural values we can see in India, it is family-centric, collectivistic, and strong academic pressure is there. In East Asia, it is collectivistic, discipline, and productivity emphasized. Western countries, we can see people are individualistic and leisure. They can do this in leisure and autonomy value. Coming to the dimension of gaming perception, gaming is always seen as a harmful or morally wasteful activity in India. So, East Asia, gaming is seen as competitive but socially concerned. In Western countries, it is seen as a normal recreation or career. Cultural framing in India, it is viewed as academic distraction or moral issue. In East Asia, it is seen as public health problem. In Western country, it is framed as lifestyle or well-being concern. Coming to access of devices, 90% in India use mobiles. In East Asia, it is PC, and in Western countries, it is more of PC or console. Coming to family or societal attitudes, in India, we can see parents discourage gaming and prioritize studies. Coming to East Asia, strict parental controls are there and curfews for minors is there. Coming to Western, parents promote balance, also moderate, they have moderate concern. Coming to policy and regulation, in India, we can see focus on real money gaming and limited mental health policy. In East Asia, we can see strong regulation, gaming limits, as well as rehab programs. Coming to Western, we can see light regulation that relies on therapy and awareness. So, assessing gaming addiction, we can see there are three tools that is culturally adapted in India, that is IGAS, GDT, and GADIS in the youth adults. So IGAS, we can see 14 items that is based on DSM and also Indian context. Merits are culturally adapted for Indian youth and it is highly reliable and also comprehensive. There are comprehensive domains. The demerits of IGAS is not mapped directly to IGD-11 and it is a longer format and it only focuses on adolescent focus. So gaming disorder test from cons, it has only 4 items. It is very brief, high validity, globally used, and it is strong ICD-11 alignment. Demerits are limited depth, optimal cutoff still debated, and there is a broad threshold. Gaming disorder scale for young adults, we can see there are 10 items, mainly aligned with ICD-11. Merits are multi-dimensional reliability as well as cultural validity for young adults. Robust ICD-11 alignment can be seen. Demerits are, it is a longer for a screening assessment, mainly it focuses on young adults and it also needs expanded validation. So what are the diagnostic challenges? We can see clinician bias arises from poor cultural familiarity and stereotypes about gaming, and tools not regionally adapted, and there are that can miss symptoms, especially in rural or non-English speaking contexts. Family and community pressures can mask or exaggerate IGD symptoms. So integrating cultural competence in IGD, we can see use regionally validated tools and local languages for assessment, include family interviews, community perspectives and strength-based approaches, and also address stigma and belief through psychoeducation and community engagement. So this is a case, R age 15, coming from Mumbai. He has excessive online gaming, academic decline, and withdrawal from rituals. Initial help from a religious leader, delayed clinical assessment, then culturally adapted tools and family involvement reveal gaming as coping for peer bullying, not just addiction. So intervention was focused on psychoeducation, family strength, stigma reduction. So concluding, we need to develop regionally adapted skills for rural and diverse population, and we should also have research and implementation towards community interventions for stigma reduction, and also foster multidisciplinary approaches, like we can include psychologists, social workers, educators, and spiritual leaders. So key takeaway is cultural competence is vital in IGD diagnosis for Indian youth, improves accuracy, reduces stigma, and enables tailored care. So we need to embrace family and community perspectives for engagement and resilience. So these are my references. Thank you. Over to Abhirams.
So now we will talk about pornography addiction. So major objectives are present culturally sensitive framework and highlighting the role of cultural competence in improving that assessment and diagnosis of pornography addiction, and analyze cultural norms and values that influence symptom expression, help seeking behavior and diagnostic pathways, and promote interdisciplinary collaboration to refine assessment tools and equip clinicians with practical strategies to minimize misdiagnosis and stigma through culturally informed assessment and diagnostic approaches. So, as an introduction, pornography consumption is in various studies saying 70% to 94% people are consuming pornography. Others may don't have internet. So, and another thing, like in English studies, okay, in the studies it is less, okay, and 3 to 5% is estimated having problematic pornography consumption, and most of the studies are saying when it is in men, it is because of the underreporting in the female, and only 40% among this having problematic consumption is approaching for any kind of treatment. In various countries, it varies, and pornography addiction is not considering as a behavioral addiction in DSM-5 or ICD-10, but ICD-10, ICD-11 now added
it as a like impulsive control disorder, compulsive sexual behavior disorder it is called. So we will go to the cultural norms, stigma and problematic use. Cultural attitudes significantly impact how pornography use manifests, and this stigma affect help-seeking behavior and disclosing that because of the shame and secrecy matters in India, it is very prominent, and contest like and self-labeling of addiction is also high in India because of the guilt, and other than true compulsivity, because of the guilt, people uh, self-label themselves as addicts. And moral framework, guilt and self-perceived addiction is high in India because of moral incongruence. People perceive themselves more as addicts, and it is hard to distinguish because of that. Distress is consuming us addiction most of the time, and religious influence is also a matter. Moral reasons, people with a low consumption level only perceiving themselves as addicts, and diagnostic challenges, major thinking, therapist moral disapproval, therapist cultural values also a matter, and stigma and underreporting is also another matter. Sometimes even people with problems don't discuss openly because people may judge them. And importance of cultural competence in assessment is also a thing. So impact of the impact on accuracy, distinguish pathological behavior from cultural and normative behavior, and value driven guilt is hard to distinguish each other. That is the problem. And therapeutic alliance also because of the clinicians moral values and all, it may causes judgment and all. The screen. Okay. Yeah. Yeah. So strategies for culturally competent assessment. Clinician can integrate specific strategies to enhance cultural competence, educate and reflect, and clinicians must willingness to learn from the client, and educated empathy. They must we must respect and understand clients' honor, shame, and religious purity, and those kind of concepts. And cultural formulation in interview, use structured approaches and all, and inclusive and non-judgmental stance we need to take, and collaboration is also an important thing. And adapting Indian standards, culturally validated tools are less, or we can say it is not there. And so validation across culture is important when we are considering about the assessments, and so, and another thing, we must need a more research collaboration to understand how the disorder is manifesting and all. So, international sex survey and all is required to understand better about the pornography addiction, and it will this all will help to increase the awareness and improve assessment accuracy and fairness. We can develop practical strategies to deal with that assessment and diagnosis and all. It will help to reduce the stigma. So that basically clinicians need to be aware and informed about the pornography consumption more, and what are the cultural things affecting that and all. Thank you.
So we just heard the symposia presented by four people about the culturally sensitive diagnostic and management areas. Two questions I'm allowing because of certain time, otherwise I would have given much time. So anyone, those who are having any doubt or any query, they can ask the question to presentee. They will clarify. If they want to add something, that is also welcome. Okay. Question, please. If somebody want to, otherwise we can survive.
Thank you so much for your presentation. This is a topic that I'm also pursuing in my thesis dissertation and MPhil. I'm Niharika Suri. I'm in Airhouse as well. So I've heard three presentations across behavior addictions as a concept. I am currently dealing with tool construction itself. So something where I have a trouble is the diagnostic blurring that we were talking about, that compulsive or impulse control or it being an addiction, right? So some of the addictions, they have insight about the distress, some do not. So for example, work or exercise or something like that is a adaptive behavior for some of them. So how do we draw the line between what we discussed as pathological or a cultural deviance to a normal adaptive functioning or to an at-risk kind of a thing? So if we are developing a tool according to you, because you've seen cases and everything, what would be those parameters at which we might draw those cutoffs?
Thanks for the wonderful question. So basically, when we are coming up with any diagnostic criteria per se, so we are always looking out for the dysfunction associated. Okay, so the same line can be done here as well beyond the cultural elements, because some things, as we are also seeing day-to-day basis, so the walking, the amount of walking that we are considering as normal. So one person, what is the amount of walking that one person considers as normal? The other person, so what is it expected across the ages? What it is expected, whether it is something that is for a treatment purpose, something that is for a well-being purpose, something that is for a show-off purpose, or something that is for, if you go for a walk in the morning, you will get to see many people, or you will get to socialize. So there are different criteria to each person conducting, like carrying out a particular behavior. So now, what is the distress associated with these things, and what is the dysfunction associated with these things, will become the primary element about considering it as whether we need to consider it as a distressing element or a diagnosable level or not. So that becomes our primary area of concern.
Just
Hi, my name is Anjana. I'm a clinical psychologist and currently doing my PhD. So, wonderful presentation specifically highlighting both food related pornography as well as gaming. Just to look forward, because all of us in this stage know that there is difficulties in diagnosis, there is difficulties in management, and especially bringing the cultural competence, because whatever management strategies we have, it's all Western. So, what do you think? What's the way forward? Like, as clinical psychologists or mental professionals representing India and having specific cultural routines for ourselves, what do you think is the way forward? Do we need more research? Do we need more tool development? What's the way forward?
Thank you for your question. So I think there are two ways forward. One is to not rely on self-reported measures alone. Is to do more of mixed methods study designs, because that will allow you to capture both the things at the same time. That will allow you to establish some cutoffs. So let's say that, and that's what I was going to answer before as well. That if we have higher cutoffs for Indian population in general, we can establish new norms, right? As well as that, doing a qualitative approach or going forward with a qualitative approach, you can also gather
symptoms that are not being captured in quantitative tools, right? So that will also allow you to capture all of these experiences, right? Another way forward would be also to train clinicians to be culturally competent. So, for example, like Abhiram sir was talking about pornography addiction, how the therapist bias itself can influence a diagnosis, right? Or in terms of Shala ma'am gaming addiction, how parents may over-report what could be normal gaming as over or as addiction towards gaming, right? So, therapists themselves to be culturally competent. So, probably some guidelines can be established as to what all of these addictions look like in Indian cultural context. So if we can maybe look forward to publishing some guideline like that and doing more mixed methods.
As you were mentioning, we need more of a multi-centric studies, basically, especially in Indian context, for us to be developing a culturally sound or culturally sensitive diagnostic tools. So as Madam was mentioning, apart from the tools, we also have to have a mixed method of assessment. So that is the way forward that we can look at.
Okay, so thank you. We are at the end of this session. All the presentees have presented very well, covered their respective area very well as per given time. That is another thing. How cultural awareness and cultural competence is affecting you? Let me share few experience and few things. Very first thing, when you will diagnose disorder, when the things are affecting their personal, social and occupational area, then only it is being diagnosed. Number one. Second thing, if you go in a tribal culture, you will find the liquor is very common. And it's not only the one person. Whole family is taking. That is different. Rice beer like that thing. If they are coming to you, in what way you will take? Because those things are having significant impact on the intervals. Let me tell you one experience. When I was doing MPhil, one of my colleague resident, he was Bengali. So for some term, particular word, patient said something and he was not aware about that. So he said that this is neologism. And neologism is a typical indicator of schizophrenia. Typical indicator. In other diseases, you will not find neologism. You will find in mania slang, but neologism is not. So we all were there. My consultant was PSVN Sarma, presently in the, he said, where is neologism? If you are not understanding that word, that doesn't mean this is neologism. So you will put the person in schizophrenia, then whole life has gone. About the addiction, what one presentee has presented, that paper was published about sweet addiction. Let me tell you about the Bengali culture and Gujarati culture. In Bangla, the ingredients of food of Bengalis, mach, bhat, bhaja, chutney and misti. Without sweet, they cannot take the meal. Even like in our culture, in here, Haryana and Delhi, after taking food, what we say, चलो यार पान खा के आते हैं, कहते हैं ना, वहां क्या कहते हैं, चलो मिठाई खा के आते हैं. So if you are not aware about that particular culture, what the Bengali culture and what the putting, like in Gujarat, they put the sugar in dal also, in sabji also. So if you are not aware about that culture, you will put it in negative direction and you will diagnose something different. That will be trouble. You have made the person who is fully normal going with the track of their own culture, you have made the patient. Similarly, in many places, gaming, task patta is very common. If you are not, especially I am telling you in Bengal, you go, you will find on every street side, 10 people are sitting and they are playing a cards. If you are not aware about that, you will simply diagnose. Those things are very important, and in India it is very difficult to understand each and every culture. But you must have little bit orientation, and if you are not having, you are dealing with the patient, please always try to take the help of someone. So they can make you aware. Like another thing, I tell you. One flower is maua. Many of you must be knowing. That is having very strong addictive property because from that liquor is being drained. In many culture, it's quite frequent to take maua when in the season on the regular basis. Will you diagnose the addiction? Alcohol? No. That's a culturally accepted, and they are on basis of culture seasonally they are taking. That cannot be diagnosed. So these are some issues which must be taken as a clinical psychologist, as a professional, when we are dealing about the diagnosis and intervention. You must be these things must be taken carefully, handled carefully. Otherwise, it will not be possible to succeed on managing the case and diagnosing properly. That's all. Thank you.
Thank you for such a wonderful symposium to all the speakers and also, sir, for chairing the session again. So now we move on to our last session scheduled in this venue, which is a free paper oral presentation. I kindly request the participants who are going to be doing the presentation, paper presentation, please to come in the front and please give your presentation to us. 2 minutes. Excuse me, your name is? Okay. Who else is there for the paper presentation? Who else is there for the paper presentation? Your name? Divya Badu. And you? Himanshi. The three of you are there, right? Anybody else for paper presentation? Okay. So for the paper presentation, I would now kindly request Professor Dr. Jayanti Pujari ma'am to come, who is the chairperson for the and judge for this best paper presentation slot. And I would kindly request Professor Dr. Sengal sir to kindly felicitate Jayanti ma'am. हाँ मैम हाँ नहीं लिया है मैम हाँ even though ma'am is part of our institute only, but just to give a very brief introduction, ma'am is the Dean, Faculty of Rehabilitation Sciences and Director, Amity Institute of Rehabilitation Sciences, Amity University, Uttar Pradesh. And ma'am's area of interest is inclusive education, disability rehabilitation, and applied research. And she has also received the Best Professional Award in Disability Rehabilitation. With Jayanti ma'am, we'll also have Ms. Rashmi Pandey chairing this session and judging the paper presentations. So there are 3 presentations and we will start with the presentation. They can use the pen drive here itself. You can come. Do you have a pen drive? Email it. Karuna, whose email is open?
Also, you have already brought through instructions, but the presentation part is completely different. If you are also using perfect. Okay. Good evening, everybody. My name is Himanshi Rangi. I'm an MPhil trainee at IBHAS, and I'll be presenting this paper titled Reflections from the Therapy Room, Ethical Breaches, Therapeutic Uncertainty, and Growth in Practice. This is co-authored by Dr. Shahzadi Malhotra, who is an associate professor at IBHAS. A very brief background on the paper. So we know that psychotherapy goes beyond just symptom reduction. It also includes a lot of complex ethical and relational challenges that we have to navigate. These include non-sexual boundary crossings as well as ethical dilemmas, which are further intensified for training therapists because of their limited experience as well as their emerging professional identities that are not very formed yet. Running parallel to these relational dynamics are also the therapist's inner world, which for trainee therapists is often characterized by a lot of self-doubt and sometimes even a sense of incompetence. And both these dynamics are sort of woven together and unraveled in supervision, where the trainee gets a space to process their emotions as well as maintain competence and prevent any harm in therapy. So, coming to the need for our study, we realize that often therapeutic work focuses more on techniques and its outcomes, but the therapist's own experiences of navigating these relational challenges are not focused upon as much. In fact, how these experiences shape their therapeutic identity, their professional growth, and their ethical sensitivity is something that we wanted to explore, which is why the aim for this paper is to explore a trainee therapist's lived experience of navigating ethical breaches, therapeutic uncertainty, and self doubt during psychotherapy, and to reflect how these sort of contributed to professional growth, boundary awareness, and ethical maturity. This is a qualitative single case experiential reflection done using narrative analysis, where we tried to capture temporal, contextual, and meaning making aspects of ethical and emotional challenges that we faced during a long term therapy with a young adult. Data sources were session process notes and reflections from over 50 sessions, and supervision discussion notes and personal reflections by the trainee. These reflections were then arranged chronologically to trace any shift in the therapist's self perception and identifying the narrative turning point. Once they were identified, we analyzed it for plot, any possible conflict, and eventual resolution of that particular conflict to understand how it contributed to evolving professional identity and ethical awareness of the therapist. Very briefly about the case, Mr. R is a 22-year-old male who presented with complaints of persistent procrastination and inability to maintain his academic productivity, intense fear of missing out on important information, repeated need to track and monitor productivity, and lastly, recurrent urges to record conversation, videos, and content on internet that he perceived as important. He had been diagnosed with OCD since the last 3 years. He perceived his family environment as being characterized by a sense of emotional distance, between his parents and himself. And he remembers himself as having a very low self worth throughout his childhood, feeling unloved and misunderstood by most people around him. He reported sexual abuse by a male tutor at the age of 12 years, which is associated with a lot of guilt, disgust, and anger towards the world as well as his parents in general. Coming to the therapy sessions, so in the first session, the client majorly talked about his procrastination and academic distress. And it was well into 15-20 minutes into the session when he randomly, very casually mentioned that he had been recording our session so far. I was completely shook at this moment and I, of course, addressed it immediately. I asked, we explored the meaning behind this act, and that is when he actually told me about his OCD diagnosis and his compulsions that had been there since the last 5-6 years. I, of course, psychoeducated him on the therapeutic process and the lines around confidentiality. But this is the first time when I felt a sense of tension in trying to maintain that empathy and maintaining that therapeutic alliance because it sort of hindered the trust building process from my end. The second turning point that I noticed was around session 9 when the client told me that his OCD symptoms had actually reduced and that he did not want to focus on them any longer. Instead, would want to talk about majorly about his productivity and academic performance. Around this time, he began giving a lot of gifts, handwritten letters, and he would reassure me that he sees me as his elder sister, and this is nothing inappropriate, but it still made me feel very uncomfortable. He wanted me to become his accountable partner, where I would keep a check on his academic performance. I would sign that, yes, he has done all this work throughout this week. And while all of this was going on, I had an internal conflict going on where I had this fear of either I'm being too rigid or I'm being too lenient. And why are these topics coming up again and again? Retrospectively, I also realized that there was a sense of idealization and devaluing conflict that was going on, where on one hand, he would tell me that he sees me as being as important as his parents. But in the very next session, we would talk about how therapy does not seem to be working. And probably he could consider seeing some other clinician or other supervisor or specialist. So I had this intense sense of discomfort and self doubt in all these sessions. And of course, I was exploring these in supervision, but it still kept on. It did not resolve completely around this time. Around the end of 23rd session, the client told me that since the last 1 week, his symptoms had actually returned, and that in the previous session, when I left the cabin for 2 minutes, he took a number of another client from the OPD slip that was lying on my table. And that was, it completely shocked me to say the least. And I explored this very, very intensely in supervision sessions for before our next session. And we decided that the other client, who happened to be a female within the same age group, they are both adults and it would be their decision whether they want to continue talking or not, as long as they don't involve me. But it did not happen as we had expected. There were a lot of mutual boundary breaches that were going on from both the clients' end. And in one session, they actually ended up coming together and asking me to resolve one of their conflicts, which is when it became very overwhelming for me and I considered termination for both the clients. And but eventually we did continue with both the clients and we focused our sessions onto our original goals. Uh, that is when I noticed a sense of clarity in my own professional role. And I moved from a reactive management to a more of reflective and relational awareness. Very briefly, the outcomes, we noticed that over time, after these 50 sessions, his academic consistency has improved considerably. We are more respectful of our boundaries, and I have a sense of professional confidence that I gained through a lot of supervision and reflective writing because of this case. And to conclude, I would like to say that ethical breaches, they are often looked they're looked very fearfully, but they can actually serve as mirrors for both the client and the therapist for their own vulnerabilities and how we can probably explore them in the future. So possibly in the future, training curriculums could include therapists' inner experiences as well. These feelings of doubt and shame and identity and how to navigate them better rather than just solely focusing upon the different therapeutic modalities and their outcomes. These are my references. Thank you so much.
One or two questions we can take. No? Yes.
This was definitely indeed a very challenging case, and kudos to you for managing it so well. You mentioned that there was regular supervision and personal reflection that you were going through. So anything, any one point or anything central to that you would like to highlight? Because when there's so much boundary breaching, which is bound to make us feel uncomfortable and bound to make us not be able to trust the client. When there's so much boundary breaching, which is about to make us not be able to feel comfortable in the session, given the gender differences as well, given the age group. So anything that came up for you that helped you through supervision or through a personal reflection that you would recommend us to be able to practice? Because these things do tend to happen in a tertiary care setup.
Okay, so one thing that consistently came up for me was whether what I am doing is right or not. Like I mentioned as well, whether I am being too lenient or unintentionally I'm being too strict, and I'm not respecting the client's requests, or let's say his way of showing that he trusts me or building an alliance. And that is what our supervision also majorly focused upon, where both my supervisor and I, we were discussing at length on what is this bringing up for me? What is it that I am not comfortable with? And what is it that I am comfortable with? And actually, we eventually landed upon that there's no right or wrong answer upon whether you can actually accept gifts from everybody or particular clients, or whether you should give him your contact, or you could tell him that, yes, these gifts are acceptable and these are not. But it is more of your own I would say value system, or how you see yourself as a therapist as well as that particular client. And that is what I eventually learned, that there is no right way. And this is not that I'm doing something wrong or utterly havoc is looking down on me. But eventually I did realize that it's okay. And whatever my version is, we went through, of course, while discussing it with the client as well, we went through with it.
Good evening, everyone. My name is Divya Badal, and I'm an clinical psychology trainee at IBHAS. And I'll be presenting my paper titled Therapists Speak and Clinical Realities, Opportunities and Challenges in Diverse Clinical Practice Faced by Mental Health Professionals Working in IBHAS. This paper has been co-authored by Ms. Simran Kumari, a fellow MPhil clinical trainee at IBHAS, and Dr. Vikrani Chatterjee, assistant professor working in IBHAS, and Dr. Vibha Sharma, professor and HOD at IBHAS, New Delhi. As psychology has entered the cultural mainstream, clinical language now shapes how people describe emotions and relationships. Terms like toxic, gaslighting, and narcissism, which were once confined to the therapy room, are now part of everyday talk. This is not entirely new. Psychological and psychiatric terms have been in the public domain since ages, but the social media has accelerated this. Psychological and psychiatrist terms are massively influencing people from platforms like TikTok, Instagram. They simplify complex psychological ideas and influence how people understand distress and even identity. So therapy speak, as defined by the authors Isam, Mas, and Almagro, is a superficial, often imprecise use of psychotherapeutic vocabulary in daily life. Now, why therapy speak matters? Because it changes how people express pain and how clinicians understand it. Patients now often come to the therapy room with ready-made psychological narratives taken from self-help spaces or maybe from the internet. There is a positive side. This shows the growing openness about mental health, but it also risks oversimplifying or even misrepresenting symptoms. For clinicians, the challenge becomes how to validate the patients and while maintaining the clarity, diagnostic clarity and accuracy. Therapy speak didn't just emerge with the advent of social media, it has been around since forever. For example, Freud, Freudian concepts like repression and denial, they entered everyday terminology. And back in psychiatry, even wartime psychiatry was present, terms like cell shock that came into public life. By the mid century, pop psychology and self help books pushed ideas like self esteem and boundaries into the mainstream conversation. This steady diffusion blurred the clinical precision, but also democratized access to psychological vocabulary. Now, this set the stage for what is today known as therapy speak. So, therapy speak operates at the intersection of culture and ethics. While it normalizes mental health discussion, it can also oversimplify or pathologize everyday emotion. In India, for instance, people often describe distress somatically. They use words like tension or heat in the body rather than psychological labels. When global therapy language dominates, these culturally rooted expressions are at risk of being overlooked. Scholars like Ivan Mas and Raghuram caution that therapists speak can even reproduce privilege, where urban English speaking voices are heard more clearly in clinical spaces. This study here aimed to explore clinicians' experiences with patients' use of media influenced mental health language and to document patient cases illustrating its clinical impact. This study used a qualitative design that combined descriptive case series and narrative interviews. Our goal was to explore how therapy speak manifests in actual clinical work. We studied 3 patient cases and interviewed 10 mental health professionals. 7 of them were clinical psychologists, 2 were psychiatrists, and 1 psychiatric social worker. All were working at IBHAS in New Delhi. So this mix of cases and professional voices allowed us to capture both patient realities and clinician perspectives. So our data collection included semi-structured interviews with clinicians and case studies. These interviews were conducted either online or in person. It typically lasted for 10 to 15 minutes. These conversations, either with patients or clinicians, explored how patients communicate their symptoms and how clinicians experience and navigate therapy speak in practice. Ethical standards were followed, confidentiality, informed consent, and voluntary participation was ensured. For data analysis, we used a narrative analytic approach. We focused on how clinicians made sense of. Okay. So moving forward, for data analysis, we used a narrative analytic approach which focused on how clinicians made sense of patient encounters involving therapy speak. This method let us explore tone, sequencing, and meaning, showing how clinicians interpreted language in real time. Narrative analysis was chosen to preserve the coherence of clinicians' stories and capture their sense making process without fragmenting their accounts into disconnected ideas. So the results included the case series as I mentioned earlier, the three core cases that illustrate how therapy speak plays out in the clinical setting. Across the three cases, S, M, and K, therapy speak acted as both a bridge and a barrier in understanding their distress. All the three clients used psychological terms learned from either internet or social media to express themselves, which at least improved articulation, but it also blurred distinction between normal emotion and pathology. For example, client S internalized therapy speak in a self-stigmatizing way. Client M used it to intellectually understand family and cultural conflicts. And client K over-identified with diagnostic labels such as ADHD and trauma bond to explain everyday challenges they were facing. These cases together illustrate a continuum from moral self-labeling to diagnostic over-identification, emphasizing the need for psychoeducation and culturally sensitive dialogue around media-shaped understanding of mental health. Clinicians consistently reported that they encounter therapy speak now in nearly every session, specifically with the younger clients, urban and social media savvy clients. On the brighter side, this has this has opened up new doors for the patients that they seek help earlier. But clinicians also describe challenges. Patients often arrive with ready-made psychological diagnoses. They resist alternative explanations and expect confirmation of what they have learned online. Most professionals manage this by first listening patiently and trying to understand the patient's meaning and gradually offering them psychoeducation and reframing the concepts within accurate clinical contexts. So, as for the discussion, therapy speak emerges as a double-edged phenomenon. On one hand, it helps patients express themselves and feel validated. On the other, it risks oversimplifying their emotions or turning everyday struggles into pathologies. There's also a cultural, there's also a cultural and ethical angle. Therapy speak often borrows from Western psychology, which can unintentionally silence local idioms, as mentioned before, like people in India used somatic terms more. So clinicians address these challenges by emphasizing relational care, listening carefully, translating meaning and context, and gently guiding patients towards clarity. To conclude, therapy speak is not just a linguistic drift as uh, presented by authors before. It is a social and cultural shift that affects how people articulate suffering. As clinicians, our job simply isn't to police the use of such language, but to guide people gently towards clarity with empathy and considering the cultural relevance. Based on the findings, what can be done further? We have noted a few key recommendations. One of them, some of which include equipping clinicians with training on media influence terminology, developing bilingual psychoeducation tools for patients, promote media literacy that helps bridge clinical and public understandings of mental health. So with that, I'd like to wrap up. Thank you. Mm. Since I'm a trainee at a tertiary care center, and I see patients coming from different diverse backgrounds, but most of them at least speak Hindi. And what we do is explain terms in English or maybe some modern terms. So we came up with this concept that we can have pamphlets which explain terms like anxiety and normal stress, depression or normal sadness, both in English and Hindi, so that it's easier for people to digest the knowledge. Thank you so much.
Good evening, everyone. My name is Ahana Ghosh, and I will be presenting my paper, Exploration of Diversity in Clinical Psychology Practice in India, a preliminary analysis of different dimensions, with my co-author, Dr. Poonam Joshi, who's also an assistant professor at Amity University, Jaipur. So this is the overview of my presentation. Moving to the introduction. So India is one of the most diverse countries in the world when we talk about in terms of languages, religion, caste, culture, classes, gender, etc. So because of this, psychologists here work with clients from very different backgrounds every day. So in such a setting, therapy cannot follow Western models. So it must be very context sensitive and also inclusive. So this is where diversity competence comes in. So which means that psychologists' ability to understand, respect, and effectively respond to differences in culture, gender, language, sexuality, now neurodiversity, and socioeconomic backgrounds. So globally, competence includes awareness, knowledge, skills, but in diversity work, it also means self-reflection and advocacy, being aware of one's own biases while working towards equality in therapy. So research has shown that when therapists and clients differ in backgrounds, say by class, caste, gender, it can also affect the trust and even diagnosis. So in India, these challenges are often multiplied by poverty, stigma, unequal access to care. So diversity competence isn't a very optional factor. It is a core ethical requirement for effectiveness of clinical practice. So currently, most Indian psychologists learn about diversity very informally and not through structured training. So our curricula still follows the Western model, which does not always fit the Indian realities, which leave the rural, marginalized societies or the non-English speaking clients very underserved. So this study focused on several key areas: cultural, linguistic, gender and sexual diversity, neurodiversity, socioeconomic and structural diversity, and intersectionality. So the study draws from various frameworks given by Su et al., Campina Bakota, Crenshaw, Ratz et al., and Bronfenbrenner. So together, these guide our main goal, basically to understand Indian psychologists' understanding and practice of diversity competence, and in the longer run of the study, to build a new tool with proposed name of which was the Comprehensive Diversity Competence Inventory to measure and enhance it. So the aim of this study was to explore how clinical psychologists in India understand and apply diversity competence in practice and to use these insights to develop the CDCI tool. So the objectives were as follows: examine clinicians' awareness, attitudes and challenges related to diversity, identify adaptive strategies, ethical dilemmas and institutional barriers, define key domains and subdomains of diversity competence, and use these findings to create an India-specific reliable assessment tool. So the rationale for this study behind developing this tool was that we do not have a proper way to measure how well Indian clinical psychologists handle diversity in everyday practice. So now diversity competence means being able to work effectively and ethically with clients from different backgrounds. So globally, this idea is very well known, but most tools measure it are Western single domain and do not fit the Indian context really. So therefore, this tool, therefore, there's no single tool that measures all the complex realities of the Indian setting. So upon reviewing literature, we found a lot of key gaps. So mostly tools only measure one aspect, not fully seeing the picture of diversity, or they assume the Western settings, ignoring things like caste, family, structures, etc., which is very different from what the Eastern settings look like. And very few include language and low literacy adaptations. Neurodiversity and disability are often treated as deficits and not differences. And institutional and systemic factors like hospital policies, lack of interpreters are rarely assessed. And also intersectionality and therapist reflection are almost missing in most of these tools. And finally, most existing tools are too long or complex for busy Indian clinics. So what we did was, with the study, it included 50 licensed clinical psychologists from across India. The purpose of sampling was used to make sure that we covered professionals from different settings and regions. half the parts, 25 were from private practice, 25 out, and the rest 25 from hospital base, out of which 15 were from private hospitals and 10 from government hospitals. The inclusion criteria was holding an RCI license, practicing as a clinical psychologist, having 2 to 5 years of experience, being actively involved in therapy and assessment work, being fluent in Hindi or English to take part in the interview, working with a diverse set of population, located in major Indian regions like Kolkata, Mumbai, Pune, Delhi, Bangalore, Chennai, Tamil Nadu, covering most areas of the map. Exclusion criteria involved individuals who are not yet licensed, psychologists not in active practice, those who are working in research or teaching line or corporate roles, less than 2 years or more than 5 years of experience, non-availability for full participation, non-proficient in Hindi and English for the interview, and those working with specific client groups only. So all participants were recruited through professional networks and institutional contacts, and they gave informed consent, and interviews were conducted online through Google Meet. Each interview was around 60 to 75 minutes each. So for the measure, so basically, this was a very preliminary study that was conducted for a much more full-blown study. So we basically assessed, we did the review of literature, and we formulated a semi-structured interview based on certain dimensions that we found out. And followed by the semi-structured interview, we had initially reached out to 79 clinical psychologists through email. 55 showed interest, out of which 50 were who made through the entire interview process. All the interviews were via Google Meet, and oral and verbal informed consent was taken. As for statistical analysis, post the interview was done, we used the thematic analysis by Baron and Clark, six-step framework in 2006 for data analysis. First, we transcribed all the interviews and carefully read through the data multiple times to understand it deeply. Next, we coded the meaningful phrases like language barrier, ethical dilemma, or institutional limitation. Then we grouped the similar coded items to form broader themes. So these themes were reviewed and refined until they accurately represented what the participants shared. Finally, each theme was defined and named clearly. As a result, we identified 11 key themes, which later became the core dimensions, which would help us in developing the CDCI tool. So the results were as follows. So we identified the 11 major themes, first being cultural and linguistic adaptation and communication flexibility. Second, systemic constraints and pragmatic adaptation. Third, emerging LGBTQIA affirmative awareness. Fourth, negotiating neurodiversity within deficient-oriented systems. Fifth, interlocking marginalization and contextual sensitivity. Sixth, self-awareness and power negotiation in therapy. Seventh, balancing ethics, law, and cultural context. 8, digital inclusion and the divide. 9, training gaps and limited diversity competence. 10, need for institutional integration of diversity competence. 11, psychologist as advocate and change agent. So this study explored the clinical psychologists in India and to understand and manage diversity in their daily practice. Through thematic analysis, we identified 11 key themes, each showing that how therapists adapt, reflect, and respond to cultural, linguistic, gender, and social differences. So these findings help build the foundation for the Comprehensive Diversity Competence Inventory, CDCI, which will help assess clinicians' awareness skills, readiness to work with diverse clients. These are my references. Thank you. Yes. So, ma'am, so this is a very preliminary version that we have done. We would like to broaden further because we are also using a term like diversity, and we can't limit diversity understanding to just 50 participants. So this is just a half of we're still continuing the study. So they have been taken from various regions, from the east, west, north, and south, the metropolitan cities, mostly. Any questions?
Anybody has any question?
My name is Shobha. I'm from Hyderabad, CP, practicing CP and a PhD scholar in MIT. My question is, it's about multicultural competencies, right? Let's say if we were to uh, implement that, how do you think? What are the future implications, and how do you think that we could go about, given that India is a diversely cultural society?
So do you mean to say how would we use this? What are the implications for this tool?
Exactly, for the study.
Yeah, so definitely there are a lot of implications. I do have it written and I'll tell you a bit about it. So definitely this would work as a diagnostic self-assessment for clinical psychologists to evaluate where they lie in terms of diversity, right? This would also help also in formulating a lot of programs and a lot of how do I say, modules, which could include diversity as one of the curricula. And if you also see the current, so the reason why I did this study also was there was a major gap that I recognized. If you see the RCI curricula, it's a 2016 curricula, which does not take into consideration any sort of diversity in terms of intersectionality, LGBTQI, etc. This was a major reason for us, for me and my co-author to do this paper and to create this tool, which could help us clinical psychologists in understanding where we lie in terms of diversity, not just awareness, not just practice, but also awareness as individuals. While I was also collecting the interviews, that was a major gap that I realized that most of the people had only one thing to say, that there was no training or supervision formal that was given to them. It has all been informal, what they have picked up on the way or what they have learned from their clients. Or
supervision there is actually.
Yeah, in supervision there is. Sorry, what I mean, I'm really sorry.
In
Thank you
training,
for
yeah,
correcting me. In formal trainings, like even when we are studying, I'm an MPhil trainee right now. We do not have anything of this sort in our curricula unless we go to our supervisor with a question like this. So it can definitely help us create competency-based modules, right? It can also help us provide certain supervision checklists. It can also help us create a baseline for us to assess how we were before, post, and then after a certain module has been given, how we are in terms of diversity, competence, post that. So that could be the major implications for this tool and the study.
Yeah. Given that my paper is also tomorrow, which I'm going to present, is also related to multicultural context, trauma-informed care, I would like to add to what you're saying. I think this could be the first layer, and the next layer could be regional, cultural competency also. Primarily that, and then next could be, region-based. Thank you.
Thank you. So the results will be declared later. Thank you all three of you for your presentation. Now we'll move to F2. There's high tea being served. Post that, we'll move to F2 auditorium for the cultural program. Thank you. We'll see you tomorrow again.